Okay, without much further ado, today I have I'm the Secretary General of Malaysian Medical Association, Dr. Arasu, and on my right hand side is Dr. Siva. He's the chairman for PPS MMA for the private section there. Okay, and we also have Dr. Benedict Singh from University of Malaya, who is assisting us with this list of speakers for today. As we all know, COVID-19 pandemic has challenged the healthcare capacity of many countries, not leaving Malaysia behind. The study increased the number of COVID-19 patients, has also stretched the ability to admit all COVID-19 patients in hospitals or low-risk quarantine centers. And as we all know, 80% of COVID-19 patients are asymptomatic and can therefore be monitored at home. So this is where the Ministry of Health has been looking and exploring how the GPs can participate, especially in monitoring the patients. So as we all know, in the last couple of months, MMA with the Ministry of Health, they have also introduced a self-declaration to conduct COVID-19 screenings for the GPs, and also we had issues on notification, also being addressed and sorted out, and also issues on change of SOP. And as of today, we have more than 950 GP clinics who have actually registered to conduct COVID screening compared to only 200 or 300 a few months ago. Okay. Now I would like to introduce Dr. Benedict Singh, who is the ID consultant with Hospital Sungai Buloh, but also at University Malaya Medical Center. Dr. Benedict, over to you.
Thanks, Dr. Arasu. Welcome, everybody. Thank you for giving up your precious Saturday afternoon. So we have a panel of us that will be speaking and that will be handling questions as well. As Dr. Arasu said, so we've got ID specialist consultants, we've got pediatricians, we've got public health specialists, and we have family medicine specialists as well from both Ministry of Health Malaysia as well as University Malaya. Yeah. So we will be, just to manage expectations as well, the things that we will be addressing will be things like the natural history of COVID, the complications of COVID. How do you pick up a patient that is that may be going down the route of severe disease, and how do you identify them, and then identify which patients can be safe to be managed at home, and how do you also identify the close contacts of that particular patient, because I think those are the things that the patient tends to be very concerned about. All right. There will be other issues that we will not be able to address at this forum. Things like what tests do we do, and infection control issues within the clinic, payment issues, notification guidelines, and referral pathways and all that. Not that those things are not important; they are important, but some of these things are still at the planning stage, and they will differ from state to state, and other things we will be putting in our online module. We are also coming up with an online module. Hopefully by next week it will be launched, and in there you'll be able to find more details. So this afternoon session is a very targeted session for doctors who already are seeing the need of patients who want to be monitored at home because they are mild and because they are low risk. All right. Okay. Without further ado, I'll pass it back to Dr. Arasu to introduce our speakers.
And now we will go to the first topic. That is National History of COVID-19 Common Complications. This will be presented by Dr. Gan Lee Fu, ID Specialist from Hospital Tengku Jafar. Now to Dr. Gan. Okay.
Can you see my slides?
Slides not yet.
Can you see my? Can you see now?
No, no, we can't see.
Okay, hold on, please.
Make it as poster, right? Make it as a poster. You can share. You can share.
Can you see my slides now?
Yes.
Can you see my slide?
Yes, Dr. Khan, we can see.
Is that a yes?
Yes.
Okay, great. Okay, let's start. Thanks everyone for spending your evening today. So I'll be going through the basics for COVID-19 in the next 15 to 20 minutes. So these are the things that I was told to actually cover today. So let's start. So if you can't remember anything else today, this is basically the take-home message for those COVID-19 who and when and how do we predict they will get severe disease. Those who develop severe disease are those with risk factors, age and comorbidities, such as CKD, hypertension, and also history of cardiovascular disease. Not forgetting obesity as well. It is very important for us to actually calculate the BMI, and those who are immunocompromised. Usually they will develop severe disease any day from day 5 to day 10 of illness. And just like dengue, we use warning signs. And it's a combination of either clinical, lab, or radiological features. Clinical include persistent or new onset of fever, persistent symptoms, respiratory compromise with associated dyspnea, respiratory rate more than 25, SpO2 less than 95%, a rising CRP or a single CRP value more than 50 milligram per liter, or dropping absolute lymphocyte count, or ALC less than 1. Radiological features are those with multilobular involvement or rapidly worsening chest X-ray. So SARS-CoV-2 is just one of the many human coronaviruses that is possible to actually cause illness in humans. It looks like a crown basically that uses a spike protein and attaches to the ACE2 receptors that is expressed along many of our respiratory airway cells. The incubation period is defined as duration from infection to symptom onset. Classically, we mentioned that the incubation period extends to 14 days. However, majority of the patients will develop symptoms before day 7, with an average around day 4 to day 5. CDC gave options to actually rationalize how to actually reduce the quarantine period safely for contacts without testing and if no symptoms have been reported during daily monitoring. And for this cohort of patients, we can actually end the quarantine after day 10. For those who were infected with COVID-19, they may develop symptoms, and the symptoms usually start after incubation period on average about 5 days, and it may begin with a pain prodrome syndrome such as headache and myalgia, followed by fever and acute respiratory illness symptoms with congestion, running nose, anosmia, cough, sore throat. Some may even have vomiting and diarrhea, and those that progress will have difficulty in breathing. COVID-19, as we know, it is not just limited to respiratory complications. It is actually involving almost every system in the body, and it may actually be responsible for thromboembolic phenomenon, and this is quite well known as COVID-19 is very pro-thrombotic. The other complications that we do hear from reports include neurological complications such as stroke, Guillain-Barré syndrome, cardiac such as myocarditis or fulminant malignant arrhythmia, secondary to myocarditis as well. And also we do commonly see asymptomatic elevated transaminases as well. In my practice, I don't routinely see severe renal impairment or mild renal impairment at all, unless they are critically ill in ICU setting. As for dermatological manifestation, it's quite common to actually see them as well, and they can actually be quite variable in their manifestations, such as urticaria, libido reticularis. It can be actually be quite flush looking, like dengue as well. This is a proposed framework for spectrum of disease due to SARS-CoV-2 infection. In the first 2 weeks, it is acute infection due to COVID-19 with active viral replication and initial host response that is responsible for many of the symptoms that I mentioned earlier on. And usually at this time, the viral test, either rapid test antigen kit or PCR will be positive. The antibody is usually not sensitive enough within the first 2 weeks to actually be used as a diagnostic tool. From week 2 to week 4, we have this post-acute hyperinflammatory illness that some patients do progress and they will have dysregulated host response and they will be in this hyperinflammatory state with multi-system organ involvement. At this time, the antibody may be positive and the PCR may be negative. In a minority of patients, there will be some patients that have this long COVID, post 4 weeks and above, and they may have some lingering symptoms, but they are usually stable with no radiological or biochemical progression. This is a diagram to actually to illustrate the progressions of COVID-19. The incubation period is roughly about 5 days. As the viral replicates and patients start to develop symptoms, majority of the patients, more than 80%, if not more, will be in the mild to moderate category with a self-limiting illness that usually end around day 11 to day 12. However, in a minority of patients, between 5 to 15%, they may progress to more severe illness that requires hospitalization with shortness of breath, ARDS, and ICU admission around day 9 and above. This diagram is very famous to actually illustrate our understanding for COVID-19. It is divided into 3 stages. The early stage, stage 1, which is dominated by the viral response phase. It is usually dominated by viral replication with viral symptoms, and biochemically there may be lymphopenia. As some patients progress to pulmonary phase, they may or may not be hypoxic. And for minority of patients that have overactive immune system with multi-organ failure, they will be entering stage 3 hyperinflammatory phase with elevated inflammatory biomarkers. In our Malaysia guideline, we categorize patients for COVID-19 into 5 categories. Category 1 is asymptomatic. Category 2 is symptomatic no pneumonia. Category 3 is symptomatic with pneumonia. Category 4 is symptomatic pneumonia requiring oxygen. Category 5 is critically ill patient with multi-organ involvement. Category 1 to category 3 are mild, but category 4 and 5 are labeled as severe COVID-19. Putting these earlier 2 slides together, this is how we actually would like to actually manage our patients and try to think in which phase they are at the moment. So category 1 and 2 will be in early viral response phase, and as those who develop pneumonia changes will be in pulmonary phase, category 2, and those who are hypoxic will be entering category 4 and 5, with dominated by host inflammatory response phase. There are several phenotypes that are quite useful to actually try to have it at the back of the mind when we manage COVID-19. Majority of the patients, as I mentioned earlier on, will be in the mild disease clinical category 1 to 3 with very self-limiting viral response phase, and most do not have inflammatory phase at all. However, there will be a cohort of patients with comorbidities that deteriorate due to the viral infection and develop severe COVID-19 disease as a result of their unstable comorbidities. There will also be another group with very severe viral response phase that is dominating the pictures, with not so much of elevated inflammatory biomarkers. At the moment, we are still struggling with the severe disease, which is dominated by host inflammatory response, categorized by its elevated inflammatory biomarkers such as CRP, with persistently low or dropping ALC and elevated cytokine. It is useful to know who are the patients that we should actually pay attention to, and we are entering into our next session on risk factors for patients with developing severe COVID-19, and those are with age. Those who are 30 years and above are at elevated risk of hospitalization and death. The older the patient, the higher the risk of hospitalization and death. In a local study, which was actually written by Dr. Ben and colleagues, we do know that majority of our patients are actually in the mild category, stage 1 to stage 3. Only less than 10% actually belong to the severe category group. And who gets severe disease are those, just like CDC, with age as a risk factor. So above 40 years old, your risk is about 5%, and the older you are, it will be increasing trend from 5 to 8 and to 9, and for those who are above 70, 22% at risk of deteriorating. If we put age together with comorbids, these are the numbers. Less than 40 years old with no comorbidity, the risk of deterioration is about 0.48%. If you have comorbidity, that will actually increase your risk by about 4%. If you are above 40 years old as well, that is about 4%. Putting together 40 to 60 with comorbidities, that is about almost 9 to 10%. And if you are 60 years old, it's about 6%. And if you are 60 with comorbidities, it's about 16%. So comorbidities, as I mentioned earlier on, is a risk factor for developing severe COVID-19 disease, especially chronic kidney disease. So let's recap again. Those who develop severe disease are those with risk factors such as age and comorbidities, not forgetting obesity, and those who are immunocompromised. They usually develop severe disease around day 5 to day 10 of illness. And we can use warning signs, which is a combination of clinical, lab, and radiological pictures to actually predict who will get severe COVID-19. Patient can develop warning sign any day from day 5 to day 10 of illness. And these are the warning signs that we use to pick up those at risk of deterioration. And these include fever, assertional dyspnea with persistent cough, persistent lethargy, poor appetite and nausea, those who are tachypneic or having low SpO2 with exertional hypoxia, those with elevated biomarkers such as CRP and neutrophil to lymphocyte ratio, or those with dropping ALC or a single ALC less than 1. Not forgetting radiological features suggestive of severe pneumonia. So I'm moving on to my last slide now. In my opinion, this is the most difficult slide actually, because not much of literature out there when Dr. Ben actually asked me to provide tips on how to do symptomatic relief. However, I guess most of you guys in the GP are more experienced in managing common colds and will be commonly advising patients how to have some symptomatic relief for their common symptoms, such as fever and body ache, using painkillers or aspirin or NSAIDs. For sore throat, use gargle. For nasal congestion, use antihistamines. We do advise them to avoid unproven traditional medicine, and this is a
Dr. Gan, we can't hear you.
I can join.
Can you unmute you?
No. Yes.
Oh. Dr. Khan, can you unmute yourself?
Can you hear?
Okay, can. Now can.
You heard my lecture just now, right?
Yes,
Was
yes.
it-
That
Okay,
was
sorry.
clear.
Because I'm actually using my mobile device, so I actually can't have two apps at the side. Thanks.
Okay. Thank you. Comprehensive and also very practical approach on the national history of COVID-19. So I believe that it will be around because the Q&A will be at the last session. So those colleagues who are at the virtual webinar, you please write down your questions so that we compile and ask the speakers towards the end. Okay, with that, thank you again, Dr. Gandifu. Now we'll move on to speaker number 2. That is on recognizing warning and red flag signs from Dr. Wong Hui Lee, ID consultant from the TPUM. Now over to you, Dr.
Hi, thank you. I'm just going to share my screen. Can everyone see my slides?
Yes, Dr. Wong, we can see.
All right, so I'll start then. So thank you very much for this opportunity. This afternoon, I'll be speaking to you about identifying COVID-19 warning signs. Hang on. Okay, so the outline of my talk is going to be about identifying warning signs. And I believe in order for you to identify warning signs, you first have to understand the evolution of the disease, be able to keep track of the day of illness, know who are at risk of severe disease, know the warning signs, and always ask about all of the warning signs when you're monitoring patients. So there's going to be some overlap of my talk with Dr. Gan's talk, but I believe repetition is important. So in order to understand the evolution of
Answer can you? Dr. Wong, we can't hear you. You need to unmute yourself. Yeah, thanks.
Sorry, it's too many buttons at the moment. So when did you stop hearing me?
You can start this slide. I think at the beginning.
This slide or the previous one?
This slide.
Okay, so I was saying, in order to understand the evolution of the disease, I need to show you the timeline of how the disease evolves. So Dr. Gan mentioned that majority of cases will have mild to moderate illness. So they'll have the first day of illness at day 0, and then things should get better by about day 10. But we do know that for some group of patients, they tend to develop severe illness and some critical illness as well. So as he mentioned before, day 5 is the day that they tend to deteriorate and progress to severe illness if they do. And that corresponds with this stage 2, which is a slide Dr. Gan has also showed you before, when the viral response tend to diminish and the host inflammatory response might then take over. And this is when we start to worry. We worry about this hyperinflammatory host response. And this is the time when patients can develop shortness of breath with or without hypoxia. They get abnormal chest imaging findings, transaminitis as well, but with a low and normal procalcitonin. And the reason for that is sometimes it can often be mistaken as another co-infection, when actually it's more of a cytokine response. So the second thing you need to know to identify warning signs is being able to understand what the day of illness is. And so for those people who are asymptomatic, that's number 1, the asymptomatic ones, the date of illness would be the first day of the swab. So the first day the swab was taken, that would be the day we calculate as day 1 of illness. For those with symptoms, day 1 of illness will be when the symptoms first start. And condition number 3 is where it gets slightly interesting. So we have some patients who get a swab done, but only develop some symptoms later. So day 1 of illness is still counted as the day the swab was positive. However, when they might deteriorate gets a little bit gray, in a sense, are they deteriorating when they develop their symptoms at day 5, or will they deteriorate further towards day 10? So this is the gray area. So Dr. Gan has already told you about the primary symptoms of COVID-19, so I won't be going through this again. But the WHO has come up with this nice little leaflet, which I thought I'd show, because they've divided the symptoms into serious COVID symptoms requiring immediate medical care, such as shortness of breath, difficulty breathing, loss of speech or mobility or confusion, and chest pain. And then they've got another category, which is most common symptoms, which is fever, cough, tiredness, loss of taste or smell, and less common symptoms such as sore throat, headache, aches and pains, diarrhea, rash, and red or irritated eyes. Obviously, a lot of these symptoms also coincide with other infections that we have in Malaysia, such as dengue. So it's important to bear those in mind as well. So this is a paper that Dr. Gan already showed you. It's by Dr. Ben and team from Sungai Buloh. And it's looking at the clinical characteristics and risk factors of those with severe COVID-19 infections. And this was done in a cohort of 5,889 cases over 18 hospitals in Malaysia of those people aged 12 and above. And the median age was 34 years. And 92% were mild cases and 3.3% required ICU. So are the presenting symptoms that we see in other countries similar to what we find in Malaysia? And yes, so we have a column of mild disease and severe disease, but if you look, they both will have cough, fever, sore throat, runny nose. What's interesting to note is that for those with severe illness, you will find a disparity, of course, with shortness of breath. So those with severe disease tend to have shortness of breath. Few of them have diarrhea and nausea or vomiting. So the purpose of this talk is to really get us to learn how to sort our patients appropriately, or, using the word triage, which is French for to sort. And triaging ensures that the right patients actually receive the right level of care. And this is especially important when resources are limited and the number of patients are high, which I think you can all agree that this is what we're facing with COVID-19 in Malaysia, predominantly in a few states at the moment. So it's important that we allocate medical resources according to patients' level of severity, and it also avoids overwhelming quarantine centers, hospitals unnecessarily with patients who are well. But we must make sure that we identify and admit patients who are unwell, patients who are at risk of becoming unwell and require escalation in care or life-saving interventions. So when we see a patient, the first assessment is really important. So when we see a patient, we need to decide whether someone needs admission, whether they can be home monitored, or if you're unsure, you should really be checking with someone with more experience. So when we are assessing a patient, we need to think about these 5 questions. So what is their age? Do they have comorbidities? Do they have symptoms? If they do have symptoms, what are their symptoms? How bad are they? And are these red flag symptoms or warning signs? All right. And who do they live with, and are they able to self-isolate are important when you're thinking about home monitoring, but I won't be covering that in my presentation. I think it'll be covered later on. So age and comorbidities are very important. Why are they important in COVID-19? So we know already from the Malaysian paper that predictors of severe disease are those in older age, so 51 years and above, and those with comorbidities such as chronic kidney disease and chronic pulmonary disease. So all of these are associated with severe disease. Is it true as other countries? So this is a paper from China with 72,000 cases. But for the analysis of fatality, they took the confirmed cases, which is 44,000. And the case fatality rate you can see here is actually 14.8% in those 80 and above, and also quite significant, 8% in patients aged 70 to 79, even though 81% of their cases are mild. Also, case fatality rate was higher among those with pre-existing comorbidities, 10.5% for cardiovascular disease, 7.3% for diabetes, 6.3% for chronic respiratory disease, and so on and so forth. Another cohort in the UK of 20,000 people. Not everyone in the UK with COVID is admitted to hospital. That's why the median age of admitted patients was 73 years, and they tend to be admitted at about day 4 of illness. And they found that there was higher mortality with increasing age in males and those with chronic cardiac disease, non-asthmatics, pulmonary disease, chronic kidney and liver disease, as well as obesity. And this is just a graph showing the y-axis is your age, increasing age, and the purple shaded area is actually mortality and death. So as you can see, as the age increases, there's more purple, so there's more death. So we can safely say that age and mortality are risk factors for severe disease across multiple countries, not just in our cohort. And that's why KKM, when they talk about home monitoring and the criteria, we discourage against home monitoring anyone that's 60 and above due to their risk of developing severe disease. So what are some of the warning signs or red flag signs and symptoms that we need to look for in our patients? So the reason why we're looking out for these things is we want to identify those with severe disease and those with potential complications or potential to get complications of COVID-19. So that's why category 2, which is symptomatic, is actually divided into mild symptoms and moderate symptoms. And those with category 2 moderate with red flag symptoms actually should be admitted. So when we are triaging our patients, we've divided it into red, yellow, and green. So anyone that triages red should be referred to the hospital for admission. Anyone that triages yellow, you really should be assessing them in person, and those that are in green should continue to stay at home. So red flag signs are things like difficulty breathing, cyanosis, chest pain, drowsiness, lethargy, a change in mental state, hemoptysis, worsening cough, skin mottling, predominantly more in pediatrics, yeah, I don't know why that keeps happening. So the fever is an interesting warning sign, persistent fever and new onset fever. And the reason why it's interesting is because you're worried that they are going into that hyper host inflammatory response phase. So someone with persistent fever for more than 3 days, we really should be admitting them for further observation. And obviously the threshold is lower for pediatrics. Those with reduced feeding and urine output and worsening diarrhea or vomiting, all of these are red flag signs. So the yellow triage level is a bit vague. These are the ones that maybe you want to keep a closer eye on and assess them in person if you can. So those with cough, those with diarrhea or vomiting, there are 2 or less, and those with dizziness, because dizziness is a very vague symptom. So you might want to assess them further. And those that will triage green would be those with sore throat, loss of taste and smell, headache, runny nose, myalgia. They don't really tend to progress to anything severe. So these are the ones that we can kind of just reassure them and continue monitoring them. I think the important thing if you're monitoring someone from home is that you need to ensure that you ask about all these red flag or warning signs at every single assessment, because our patients change and they're dynamic. And so Dr. Gan has mentioned about warning signs, but I just want to draw your attention to the examination bit. So if you have access, or if your patients have access to a pulse oximeter, this is actually really helpful because a lot of them are actually silent. They have silent hypoxia, so they don't tend to realize that they are breathless. So if they have an SpO2 of less than 95%, that's worrying, or if they have exertional hypoxia. So what is exertional hypoxia? So this can actually be examined via 2 ways. One is a 1-minute sit to stand test, where you sit and stand for a minute and you do a pre and post pulse oximeter reading, and you are looking for a 3% drop in pulse oximeter. That's bad. Or another test would be an unvalidated 40-step test. So you just ask them to take 40 steps on a flat surface. Obviously, if someone is already hypoxic, you don't ask them to do this. So I think I've got another 5 minutes or so to talk to you about some case examples for those that we're home monitoring. And you will only home monitor people who you think qualify for home monitoring. So nobody elderly and nobody with comorbidities. So just as an example case, we'll give case A, Mr. Farhan. So Mr. Farhan is a COVID-19 positive patient currently self-isolating at home. You know, if you're going to home monitor him via the phone, how would you start the conversation and what other information would you want to ask him? And these are some of the basic things that you would want to ask and ask at every single monitor. So for example, you want to introduce yourself, establish your rapport. You want to get your patient's name, their age, their day of illness, the right day of illness, whether they've got any comorbidities and whether they have any warning signs. So after getting all of the information, you might find Mr. Farhan is a 42-year-old man, swabbed 5 days ago for COVID-19, and he swabbed himself because he was having fever and lethargy for 2 days before that after coming back from Langkawi, and he has no other medical illness. And he says he's experiencing loss of smell, but no other symptoms. So the things you need to ask yourself again is what day of illness is he, and what triage group he's in, and what would your advice be to him in this case? So for him, we would say he's day 7 of illness because his onset of symptoms predated the swab. But I would say at the moment he triages green because his only symptom is a loss of sense of smell. He's not had any more fevers or feeling lethargic anymore. So we can reassure him and continue monitoring. So that's an example of one case. Another case, Madam Munira. So you've been asked to call Madam Munira for home monitoring. How would you start the conversation and what information would you ask for? So I know, again, this is repetition, but I think it's very important repetition. You want to make sure you know whether they have comorbidities or not, and whether they have any warning signs and what day of illness they're in. So after asking all of that, we've established that she's a 55-year-old lady. She went to the surau near her house and she was swabbed 3 days ago because she was told one of the surau congregation tested positive. She denies any medical illness or medical history, but when you're probing a little bit more about your warning signs, she informs you that she feels a bit out of breath when she goes up and down the stairs of her house, but that is actually her normal. So she says she feels well, no fever and no cough. So we want to again establish day of illness, and are you worried about her, and what triage group is she in? So, you know, I'll give you guys a minute to think about this one. And basically, I would say she's day 3 of illness from her swab because her breathlessness has already predated any form of exposure. And for her, she would be either triaged yellow or red. And I think that majority of people would have triaged her as red with the breathlessness, but I think that some might triage her as a yellow. Yellow means you want to assess her further. And the reason for this is, if someone is already having pre-existing breathlessness even before that, even though they deny any medical history, you need to be thinking whether they have some pre-existing condition that hasn't been diagnosed, like a chronic lung disease or an undiagnosed ischemic heart disease, which then puts her into a high-risk category, and you wouldn't just home monitor her, and she should be monitored in a hospital setting. And if we have time, we'll just quickly go through Mrs. Lim. So Mrs. Lim, COVID-19 positive, same thing. We want to ask our basic questions. Day of illness, presence of comorbidities, and any warning signs. And I've also put another question to ask about, would you ask about BMI? And I think that's something we all forget to think about, especially when obesity is a risk factor. So this may be an additional thing that you would want to check with your patients. So we get that she's a 47-year-old woman, administrative clerk. One of her co-workers tested positive, so she swabbed herself. She's a chronic smoker of 20 pack years and no other comorbidities. Are you worried about her? She describes that she has central chest pain starting in the morning, 3 out of 10, no radiation, occasional chest pains before an exertion, but this is her normal. So again, how would you triage her and what is your advice to her? And I would say she's day 4 of illness, but I would triage her as red because she's having chest pains and we should definitely arrange for admission to hospital. And even though the chest pain is mild, she should still be triaged as red because we do need to rule out ischemic heart disease, pulmonary embolism, or pneumonia. So those are the 3 cases as examples of what you may encounter if you do practice home monitoring for your patients. And just to summarize again, in order to identify warning signs, you need to have even thought about COVID. Okay, so we need to understand the evolution of the disease, keep track of the day of illness, know who are at risk of severe disease, know the warning signs, and always ask about all warning signs at every visit. And that's it from me. Thank you very much.
Thank you, Dr. Wong. I think you have actually given us a very, very important information, especially on the day to diagnose of the illness. I think quite a number of questions been asked by our members, the doctors there. And then with this, we move on to the next one. There is COVID-19 assessment in PICS. We introduced Dr. Sheena. She is also ID consultant pediatrician from Hospital Sungei. Over to you, Dr. Sheena.
Hello, thank you very much for giving me the opportunity to give a talk in these 2 days. All right, let me just share my screen first. Can everybody see my screen?
Yes, Dr. Sheena, we can see.
Okay, all right, thank you. Okay, we had a very comprehensive lecture regarding COVID-19 disease and its complications. And let me just give a little bit introduction in our pediatric population. So as we can see here, in contrast with other respiratory illnesses such as influenza, RSV, which actually affects predominantly in children in COVID-19 have less severe disease. Why is that so? So we have already known that the COVID-19 has attacks the angiotensin converting enzyme 2, which is the main receptor site of entry of this SARS-CoV-2 into the human cells. So the expression of this ACE2 is increased with age. Hence, that's why we see the older you are, your severity increases. And children have ACE2 enzyme as well, but with the lower affinities of these receptors. Hence, they are most of the time asymptomatic, or they come in with some other concomitant diseases such as bronchiolitis or acute exacerbation of bronchial asthma or viral-induced wheeze. There is something interesting in the pediatric part when it comes to the inflammatory part, where it happens usually after the infection itself, probably 1 week to 1 month of post-COVID-19, even though they might not even have any symptoms during the initial period. So this is known as the multi-system inflammatory syndrome in children, MISC, which has been reported by US. But do we see in our country? Yes, but not so frequent. We did see about 2 to 3 patients with this syndrome itself. So this is actually not a disease. However, it's a constellation of multiple symptoms that we see the child have. So they can actually have inflammation of the heart, the lungs, blood vessels, kidneys, digestive system, brain, skin, even eyes. So this picture that I'm showing in my slide here shows nicely regarding the symptoms that we have to look for, such as fever, myalgia. So with a child with fever and comes in with conjunctivitis, rashes, lymphadenopathy, stomatitis, or maybe even extremity swellings like the tip of the finger and toe swellings, or even hand and feet swellings, as well as skin peeling. They can even show signs of inflammation in the gut area, where the symptoms are nausea, vomiting, abdominal pain, diarrhea, Some of them might even show symptoms as lethargy, which we actually have to take serious concern into it. And when it comes into the infiltrates to the heart, there's myocarditis. They could even have coronary aneurysms, tachycardia, hypoperfusion. When it attacks the lungs, when you have infiltrates in the lungs, you have pulmonary infiltration, chest pain, hypoxemia, and even renal failure. And some other, they might not present with all these symptoms. They could just have 3 or 4 of these symptoms, and also with the laboratory finding of high inflammatory markers such as high ESR, increased LDH, increased procalcitonin, D-dimer, increased liver functions, we can actually make the diagnosis of MISC. Treatment for this would be most of the time steroids or IVIG. So this is just a revision of the clinical staging. In pediatric, we use the same staging, category 1 to category 5. Today, we will be talking about how do we assess for home monitoring. So home monitoring are the mild patients where category 1 and category 2 will be fit for this home monitoring. So we have divided category 2 into mild and moderate. If the child is in category 2A, mild, he or she can be continued for home monitoring, but will need assessment. However, if the child is in category 2B, moderate, we have to admit these children. So what are the symptoms in the mild? Is usually just sore throat, a bit of runny nose with no difficulty in breathing, cough. Note that when they have cough, they must not have any difficulty in breathing to be in the mild stage. Fever, usually we take it about 24 hours, less than a day. Diarrhea, vomiting may be present, but they should not have any signs of dehydration, and the symptoms shouldn't be prolonged more than 3 days. And of course, the child must be active and be able to tolerate orally well. How about the category 2B? So these are the red flags that we should be watching out for. Difficulty in breathing. The child might be tachypneic, so the parents might give the history or complaints of she feels that the child is breathing fast. And chest pain. For younger children, they might not tell you, the parents might not know. However, the older children can actually state that they might have chest pain. Lethargy. Lethargy is something the parents can actually tell to you, or bigger children can even tell that they are tired. Reduced oral intake in any age is a red warning sign. And worsening respiratory or GI symptoms or persist more than 3 days. Fever more than 1 day, which is if you have fever than 2 days, we actually recommend unit admission because we need to monitor in case they are actually developing MISC. Fever with rash or abnormal bruises, these are also the red flags that we are suspecting MISC. And signs of dehydration such as reduced urine output, sunken eyes, dry mucosa, altered mental status and behavior, seizures, and of course, signs of shock such as cold and clammy peripheries, poor perfusion, molted skin, and pale. How do we screen a child? So if the child is in the older age, probably around 5 years and above, they could be willingly letting you to examine them or easily telling their parents what they feel. However, younger children, that could be a bit challenging. So these are the normal range of pediatric different age group heart respiratory rate and heart rate. Unfortunately, it's not as simple as adults where everybody gets the same respiratory rate and heart rate range. In pediatrics, as we already know, different age group gives us different rates of respiratory as well as heart rate. So we need to know these normals before we can detect the abnormals. So we have here the ranges from birth up to 12 years old, because that's the pediatric age group, because usually after 12 years old, the heart rate and the respiratory rate correlates with the adult. So from birth, for example, the child at rest, respiratory rate would range from 25 to 50. So we actually have to properly count it for 1 minute, as newborns might even have paradoxical breathing, where they breathe fast at few seconds and then they breathe a little bit slow. So if you are taking just 10 seconds counting for this newborn baby, you might get tachypnea when the child is actually breathing within 25 to 50 per minute. So a proper respiratory rate, heart rate counting should be at least 1 minute. So these are the ranges that you can see, and also the ranges heart rate. So anything above or anything below is abnormal. So these are the ranges that you have to look for. So for example, a 2-year-old breathing at just 15 breaths per minute, it's not normal, because normal is 20 to 30 breaths per minute. So we not only have to look at the tachypnea, we actually also have to look at bradypnea, because these are the red signs of the child being unwell. So this is a pediatric early warning scorecard, also known as the PEW score, which is used in most of the ED centers to actually triage children into green zone, yellow zone, or red zone when they're assessing patients at the triage. So this is actually very helpful for us to know whether this child can be home quarantined or needs admission. Basically, any child who fits into the green zone, where the score is 0 for cardio, respiratory, and behavior, gets to stay at home. And anyone above it, even if the cardiovascular is 0, behavior is 0, but the respiratory gets a 1, it is an indication for urgent referral. So this is how we actually see all the details. So I'll go through it one by one. The cardiovascular, where you see in green, they will be less than 2 seconds, same as adults. For stage 1, where the child might be pale, or the capillary fill time is around 3 seconds. When you have the orange zone, the child might have capillary fill time of 4 seconds. Tachycardia above 20, above the normal rate. So if the heart rate at normal was 110 and you counted the child to have heart rate of 130, so it's 20 more than the normal heart rate, hence this child is having tachycardia. At the 3rd level, of course, this is a red zone where the child needs immediate resuscitation, probably in decompensated shock, so the skin is gray, mottled, capillary time more than 5 seconds, with tachycardia more than 30 seconds, and note there's also bradycardia. So we have to be very careful when we're assessing these children. When it comes to respiratory, so what we see is the respiratory rate, of course, and the recessions, the contractions. The contractions means recession. So as my table 1.2 have elaborated, what are severity of these retractions? So when you say mild contractions, it is subcostal and substernal retractions. Moderate, intercostal and supraclavicular, and severe is suprasternal and sternal retractions. So children have compliant chest wall, so any difficulty in breathing, you can actually see the symptoms already very easily. And the respiratory rate, when it's in yellow, is 10 above the normal respiratory rate. When it's in orange, is more than 20, and in red, more than 30. And note the contractions. And also the saturations. So anybody needing oxygen obviously needs a hospital admission. And how you categorize them into yellow, orange, or red is the requirement of oxygen. So in yellow, in room air, of course, no oxygen needed. And if they need about 2 liters per minute, they are then category 1, 4 liters per minute, then category 2, and 5 liters per minute, then category 3. Behavior. Usually a child, if they are mildly unwell, you don't even know that they are actually unwell. Maybe they are having fever, but everything else is normal. They can eat, they can well, they're playing, they can sleep well. Nothing to worry about it. However, if the child is irritable but consolable, so this is also a warning sign. The parents will actually tell you, especially for the younger children, the parents will say, today my child is very irritable but just wants me to carry. So the consolable by carrying. So this is irritable but consolable. Then we have the stage 2, where the child is irritable and inconsolable, restless, in pain. So this is the orange stage. And when it comes to stage 3, we don't want to see this. reduced response to voice, pain, and this is definitely drop in GCS. Another extra points that we need to see in pediatrics is dehydration level when we have AGE, because it's one of the common symptoms that we do see in pediatric age group, probably not even related to COVID or maybe related, is dehydration. So which part of dehydration that can stay at home is the first stage, plan A, where the child is less than 5% dehydrated. So basically you don't see anything wrong with the child. The child has AGE symptoms, but still well alert, no sunken eyes, able to drink normally, the skin goes back immediately, which is the skin turgor, and there are no signs of dehydration. So this child can be given fluids and food to treat the diarrhea at home. However, if the child has more than 2 of the above signs in the second stage, this child requires the rehydration therapy by IV drip. So the child can be either restless, irritable, have sunken eyes, drinks eagerly. This child is really thirsty. That means some child, they just vomit out and they just want to drink and drink and drink all the time. You can actually see that, oh, this child is very, very thirsty. This child can finish few liters of water. I've seen some just keep on drinking even though they are just, after drinking, they'll be vomiting back. So these are the warning signs actually. And the skin turgors is reduced. That means the skin goes back slowly. This child needs to be admitted for IV therapy, IV drip therapy. And the last stage, when there's more than 10% dehydration, is an urgent referral. The child will be lethargic. We don't want the child to be unconscious, but the child might appear unconscious, with sunken eyes, unable to eat or drink anything, and reduced thick skin turgor. So this child needs resuscitation fluids. This is my last slide. This is just a bit of revision on how do we actually see sunken fontanelle, sunken eyes, and the loss of skin elasticity that I was mentioning. So we can see this very miserable little baby here drawing. And what is special about children less than 1 year old, their fontanelles is still open. Hence, you can actually assess the hydration through the fontanelle. So as you can see here, it's obviously sunken. But if you can't see because the child has hair, you touch it and you will feel the fontanelle sunken. Sunken eyes, it's quite common, you can see. And the loss of skin elasticity, that means you pinch the skin, it doesn't go off within 2 seconds. So that is definitely loss of skin turgor and skin elasticity. Thank you very much. I shall end my slide now.
Thank you, Dr. Sheena. You gave a very comprehensive talk on the COVID-19 assessment kits. And we all know that it's not easy to do, especially in the pediatric cases. And it's important for us to assess on the early signs and also the later signs. Okay, thank you again for this. And then we hope that the speakers will also share the slides later, of which MMA will email to all the participants and also put in our websites for others to see as well. Okay. Now we move on to topic number 4 today. This is also a very, very important topic. This is also a topic that issues that we face as GPs on the ground. That is identifying and advising a close contacts. Now I'll hand over to Dr. Benedict Sim, ID consultant from Hospital Sungai. Over to you, Dr. Benedict.
Thanks, Dr. Arasu. One of the main concerns that we had when we started allowing patients to be at home is what happens to my family, you know, and those who are living with me now. So I thought that this was actually very important to cover who is defined as a close contact and how and what do we do with this close contacts. Now, in order to do this well, we actually need to go through a few slides on how COVID-19 is transmitted now. Yeah. So so there are various ways in which COVID-19 can spread from one person to another. You've got contact or droplet. Contact, that means you touch another person, or droplet, that means you are within a very close range, within a 1 meter distance, and the person breathes whatever you are breathing out, or whatever you are sneezing out or coughing out. Okay, and then there's aerosolization. Aerosolization, that means you don't have to be within 1 meter. You can be as long as you're in the same room. The air particles will float in the air and eventually reach you. And if you are there for a long enough time, you may have breathed in enough inoculum to cause you to be sick. Then there's fomites, which is if I touch the doorknob and somebody else comes later on and touches the doorknob, will he get COVID? And there's also other, and when we look at the RNA of COVID, is also excreted even in the urine and feces as well. Yeah. But I think a very important point to note is that COVID can only come into your body through your eyes, your mouth, and your nose, mainly through your nose. Okay, and the main way in which COVID spreads is by droplet spread. Okay, that means coming within 1 meter of somebody and you are unprotected and that person is not wearing a mask and you are breathing in the whatever he's expelling out, and if you breathe enough of that air in, then you get, as with all other infectious diseases, you have to breathe in a certain critical mass of inoculum in order to be able to fall sick. Of course, nobody knows the exact infective amount that is needed, not for COVID, or in many other diseases, they have quantified what is the infective amount. In COVID, they haven't, those studies have not come out yet. Yeah, but in essence, so if you fleetingly walk past a guy who's got confirmed COVID and he wasn't wearing a mask and you weren't wearing a mask, you would not get COVID from him. Okay, but it may be a very different scenario is that as you walk past him, he coughed directly upon you. Okay, then the inoculum that is released to be bigger. Okay, it is important to, I think there was an opinion piece that came out in the Nature journal, I think a couple of days ago, where they were saying that there was too much emphasis being put on fomites, as in cleaning surfaces and cleaning areas where commonly touched areas. It is overemphasized perhaps for several reasons. Number one is, yes, if you go into a room of somebody who's got COVID and you swab the surfaces, whether it's the walls or the floor or the doorknobs or the tabletops, you can find some RNA of COVID. Okay, but whether that amount of COVID is sufficiently big enough to cause an infection in somebody else is not. Most of these studies do not look at infectivity. They just look at whether there is a genetic material of the virus there. Okay, and secondly is that depends on what the surface is. There are different survival times depending on whether the surface is cardboard or plastic or cloth or wood or metal. Yeah, and thirdly as well, and this is important for us healthcare professionals, you know, when suddenly there's a patient that comes into our clinic and we find out that he's got COVID. Okay, even if the surfaces are contaminated, we can only get ill if our hands touch that surface and then our hands go into our eyes, our nose, or our mouth. Okay, because that's the only portal of entry. It cannot go through intact skin. All right, so that's why I think in hospitals we emphasize, especially so with COVID, we emphasize a lot on hand hygiene. Okay, because I cannot promise you that the wards where the patients are is completely clean of COVID. You know, there will be surfaces that are contaminated with COVID, but if you make sure that your hands are you do hand hygiene before you touch your eyes, mouth, or nose, then you will not be introducing the germs in that. Yeah. So primarily through droplet transmission. Okay. I want to spend a few slides on airborne transmission, because this also gets a lot of highlight. You know, what happens if I'm sitting in the same vehicle, whether it's a bus or an aeroplane, with somebody, or I'm in the same room with somebody with COVID, or I'm in the supermarket and they tell me that somebody there has got COVID. Yeah, so there have been a few studies. You might imagine that these studies are actually not that easy to do, because they can only do them in places where there is actually either no more COVID or extremely little COVID, in order to be able to do these kind of studies. Yeah? So this was one of the famous examples that they gave. This was in China, but out of Wuhan in the early days of COVID. And basically it was people who came from town A and went to town B to attend religious activity, and they sat in two buses. Okay, bus one had I think 60 people, bus two 60 plus people, and they met at town B, and there they had a 150-minute worship event together, and after that they came back another 50 minutes sitting on the same bus where they went in, and then the next day or the following day, they found out that somebody in bus 2 actually had COVID, and they tested everybody from bus 1, bus 2, and those who were there in the temple, who didn't sit in the bus. Yeah, and they've calculated how many people contracted COVID, and they found that those 50-minute open air worship were much less likely to contract COVID compared to those who were sitting within the bus. So this study actually taught us two things. One was that COVID can spread when you have a small enclosed area with no ventilation. It can spread beyond 3 feet. Okay, it can spread beyond 1 meter, because when we looked at the bus, some people were sitting at the back of the bus and they also got COVID, even though they were sitting very far away from that index patient. And the other thing that it showed us was that if you're out in the open air, it's much safer than being in an enclosed area. Okay, and I think the clever mathematicians calculated, and they say that if you're out in the open air, you are 11 times less likely to contract COVID compared to if you are in a small enclosed area with no ventilation. Okay, so 11 times is really significant. I think many people now are talking about COVID vaccines. You know, vaccines, I think the best vaccines that we have can protect somebody by 10 to 20 times protection. Being outdoors also gives you that magnitude of protection. Yeah? This is another, these are also studies in Japan, and in this one, they said that in an enclosed area, you are 18.7 times higher odds of contracting COVID if you are indoors, and that most of the super spreader events have happened when people are indoors. Yeah? And this is another famous study also in China, and they found that when people were sitting in a restaurant, and there was an index case over here, and they found that the people in the surrounding tables contracted COVID. Okay, and these people, they were beyond 3 feet away, but they were in a small enclosed area with recirculating air. And it also looks like people who are spend a longer time there are higher risk of getting COVID, which is, I think, fairly self-explanatory. The more you breathe in, the more dirty air you breathe in, the higher the chances of getting COVID. Because these people in table D, even though they were sharing the same air, they were there only for a short while and they didn't get COVID. So in summary, this is in a simple form. I find sometimes patients appreciate this. So there are several things that determine your risk of getting COVID. Whether you are wearing a mask or not, whether you are there for a short time or a long time, whether the place where you are in is a high occupancy or low occupancy area, whether it is outdoors, well ventilated, or whether it's poorly ventilated indoors, and what activities were going on there. If everybody was quiet over there, it's in a library, it may not be as dangerous as if somebody is in a indoor concert shouting and singing away. Yeah. So so I use this as well, even for my own family, when in the days before the MCO, when they wanted to go out and eat, my first criteria is always give me a restaurant where nobody goes to and it's outdoors. Okay, if it is a famous restaurant and you have to sit indoors in air-conditioned rooms, we won't be going there. Yeah. So so crowded and closed areas facilitate transmission, and the longer duration, there's greater risk of transmission. Airborne transmission is possible when you're in a small enclosed area for a long time now. Okay, so the next thing is about the period of infectiousness. Okay, so I've got COVID. All right, I've got COVID. Let's say. So today is Saturday, and I start getting my symptoms at 12 noon on Saturday. So at 12 noon, I get a sore throat, I get a fever. Today is the start of my symptoms. When was I most infectious to my family? I would be infectious to my family 2 days before my symptoms started. So that means 12 noon on Thursday. Okay, I would have already been able to start infecting people around me, either my colleagues or my family, and it goes on. And after my symptoms start, then the infectiousness becomes less and less. And beyond 5 days, I actually so every day that goes by, I become less and less infectious, and beyond 5 days, I'm actually fairly non-infectious already. Okay. So this was seen in this study, I believe it was in Taiwan, and so they've got two groups of people there. One was people who contracted COVID, and the other was people who didn't have COVID, and these were the days when they were exposed to the index person. So this was, I think, they took 100 COVID patients who actually met with different people on different days, and I think altogether there were like 2,000 over people and all that, and I think out of that 22 of them contracted COVID, and those who contracted COVID tended to be exposed to the patient before the time of the symptom onset. Okay, and so day 0 is when the symptoms started. Before symptom onset, they were exposed to the patient and they got COVID. Okay, and then after day 5, nobody else who was exposed after day 5 got symptoms. All right, who eventually got COVID now. And if you look at those who didn't get COVID, all the contacts, the 1,000+ people who didn't get COVID, this was when they were exposed to the patient. Okay, yeah. So based on these studies, it looks like people are most infectious around the time when the symptoms start, just about a couple of days before that, and at least a couple of days, at least up to 5 days after that. Yeah? This is another slide to tell us that CT value. So when we send for a PCR test, the result comes back as a CT value, and the CT value is inversely proportionate to the viral load or how much germs there are. So the higher your CT value, the less germs are there in your body, and vice versa. So depending on which study you look at, some studies find that beyond a CT value of more than 24 found that they couldn't grow the virus anymore. When they couldn't grow the virus, basically they are saying that this is all dead virus. This is dead genetic material, and you're still picking up the genetic material, but it's no longer infectious anymore. Okay, and in this study, it was beyond day 8. They couldn't find after day 8 of symptoms, the patients just couldn't demonstrate any more culturable virus from their respiratory samples. Okay, so for every increase in the CT value, the chances of the patient being infective actually comes down. Okay, we generally use day of illness as a marker of how infectious the patient is. In hospital settings, sometimes we use a CT value, but in an outpatient setting, it may be difficult because sometimes when a patient comes with a CT value of 30, for example, we might not know whether, especially if the patient doesn't have symptoms or the patient is mildly symptomatic, or we are uncertain when the symptoms started. We don't know whether the CT value is on the way up or on the way down. And so it can be tricky trying to draw conclusions based on CT values. And different PCR machines give you different CT values even for the same sample. So there's also some inter-machine variability. I think for most studies, they find that above the CT value of 30, the patient is no longer infectious. This is another line graph. So day 0 is when symptoms onset begins, peak viral load. Patient is very infective 2 days before, up to 5 days after. Majority of secondary infections have occurred before 5 days. Beyond 10 days, the virus has been unable to be cultured in mild to moderate illness. Mild to moderate illness is defined as patients who do not need oxygen. So beyond 10 days, they are no longer infectious. Okay, but it is not the same in patients who are critically ill, okay, patients who get severe COVID and need oxygen or end up in ICU, or patients who've got the immune system that is compromised. These patients, they can actually culture viruses right until day 15 and even beyond, but not beyond day 20. Okay. However, if you do the CT values, the PCR can continue being positive right until 3 months and sometimes even beyond. I think we have seen even up to 5 months later, the PCR can still be intermittently positive. So PCRs are not good tests to know whether the patient is still infectious or not. Okay, so we use a time-based definition for when a patient is infectious and non-infectious. Okay, for mild patients, 10 days after the symptoms have started. For severe patients or immunocompromised patients, at least 20 days. And this is what it shows us in this infographic from KKM. You know, if you don't have any symptoms, then we don't have a day 1 of disease. Then we take the day of your test, and 10 days later you can stop your quarantine. If your symptoms started before your test, then at day 10 after symptoms start, or day 8 after your test is taken, you can actually stop your quarantine. Okay, this is provided your symptoms have improved, okay, and it is a mild disease that you have, okay, and you're no longer taking fever medicines, you know, so you're no longer needing PCM and NSAIDs and all that is more than 24 hours since that has happened, then we can actually stop, okay, and some patients, the test is done first because, for example, they were contact traced as part of a family. They were positive, but the symptoms started 5 days later. These patients will be quarantined until 10 days after the symptoms started, not after the test is done. So just a reminder again, crowded situations make COVID spread easier, close physical contact, enclosed space, and the duration of exposure. And what helps to prevent COVID from spreading is wearing a mask, staying apart from each other, washing your hands, cleaning and disinfecting. How effective are actually face masks? It depends on which study you have looked at. They looked at surgical mask, N95s, or even cotton mask, and they found that there's actually quite a the odds ratio of contracting COVID is 0.15 compared to somebody who doesn't use any coverings, facial coverings at all. Okay, this is another study where the virus droplets were noted in 3 out of 10 samples collected without face mask, but with face mask it's only 0 out of 11. Okay, and in aerosols 4 out of 10 without face mask versus 0 out of 11. Yeah? So face mask, of course, N95 is better than a 3-ply surgical mask. Surgical mask is better than a cotton face mask. A cotton face mask is better than nothing. Sunlight, just being exposed to sunlight for long enough actually kills the virus as well. Sometimes if I have to, in the days when we were very short of N95 mask, sometimes keeping it in my car throughout an afternoon, I know that the next time I use the N95 mask, the N95 mask is sterile already, because it's been in the sunlight for long enough. And of course, if you have to clean surfaces, or if you clean, what do you use? Use at least 60 to 70% alcohol, or hydrogen peroxide, or sodium hypochlorite, which is basically Clorox. Okay, and then you got some other chemicals which are slightly less effective. So when it comes to contact tracing, and these are the principles of contact tracing. We want to identify and manage the contacts, okay, to support early diagnosis and interrupt onward transmission. So it involves prompt identification of contacts. All right, I think it is an open secret that in places like Klang Valley, this has actually fallen through. Okay, and that's probably one of the reasons why the outbreak is as large as we are seeing it now. Okay, I think all of us would have had friends or family members or neighbors who have informed us already that they've got COVID. Yeah. Okay, so one of the key ways in which we want to, if we want to get this thing under control, is prompt identification of close contacts. Okay, and after you've identified them, convincing them that they need to go into self-quarantine, okay, take care of their hygiene, and reassure them what to do if they do develop symptoms. Okay, and all high-risk exposure patients, people should be tested. Okay, whether or not they've got symptoms, they should be advised to go for testing. But more important than testing is actually to freeze what they are doing and to go into quarantine. Okay, to go into to stop moving around. Okay, stop going to work, or stop taking public transport, or stop interacting with their family members. Okay, sometimes we may even need to test low risk exposure contacts. These are people who are not necessarily close contacts, but they may, not sure whether they are not at high risk of getting COVID, but we may want to test them if they are going back to a population that is very a very high population, fixed population. For example, if they're going back to a prison, or they're going back to a hostel, or they're going into a very crowded area, okay, or which includes hospitals as well, okay, or if they're going back home where they've got very elderly parents or very vulnerable people, sometimes even low risk people will need to be tested as well. And if any of them develop symptoms during the incubation period, they should be tested. I thought it was easy preparing for this talk on close contacts, until I realized that there were actually many questions when it comes to close contacts, and it's actually not an easy task. And I really take my hat off to the public health people who have been doing this on the ground for the last 1 year plus. It is really a very difficult job, because taking a history of who is a close contact, and what activities the person has done since his symptoms start, 2 days before his symptoms started. We normally started 2 days before the symptoms start. So if like my symptoms start today at noon time on Saturday, so the person who is doing the contact tracing will need to ask me from Thursday noon time, who have I been with? Where have I been at? Have I been in meetings that were closed door meetings in small rooms? Have I been sharing transport with anybody? Who do I live with? Who are my colleagues? Were my colleagues wearing masks? Was I wearing a mask? Did I have meals with anybody? did I get any visitors who came to my house? Were there any plumbers that came by, or people that came into my home? So actually it's really a full clerking to actually get. For some people it's very straightforward, maybe some people lead very antisocial lives, so oh no, I didn't meet anybody except for my wife, and nobody else. Okay, so then it's very clear who their close contact is. For others, some of the patients may be public figures, they also may not even remember who they have come into contact with. All right, and if I ask all of you also in the last 48 hours, where are the places you have gone to? Many of us actually need to take out our handphones and actually look through where have we gone through, and that's one of the techniques that actually is also been recommended. I'm looking through your social media, if they are social media savvy, or some of us use this Google Maps, and Google Maps actually can tell you where you have been in the last, where you've traveled to in the last in the last few days. Okay, so identifying who is a close contact is it can be very tedious sometimes. All right. And what happens if any of these close contacts become symptomatic? As I mentioned, they need to be tested, and if any of them are positive, then the whole suddenly there's a new bubble that opens up. Because if a close contact becomes positive, or it's tested positive, then we need to ask that close contact, where have you gone? Who are your close contacts? So it suddenly becomes another bubble that needs to who is within that person's bubble itself. Okay, how long we need to quarantine for? I think earlier Dr. Gan, Dr. Puili did mention that the incubation period for COVID is up to 14 days, but once 10 days has come, and if the person doesn't have any symptoms at 10 days time, this patient will be considered very unlikely to develop COVID after that. All right. Is exit testing needed? That means at the end of 10 days, is it needed? Ministry of Health at the moment has said that you don't need to test a person who is asymptomatic. But for all of you, you are not working within the ambit of Ministry of Health, you can test. I personally would test people who at day 9 or day 10 after their exposure. All right. Sometimes we need to get collateral history of who is a close contact. Okay, because as I mentioned, the person could be a public figure. He may only remember 30% of the people he has met. And only when we ask his other close contacts, there's oh yeah, I actually went with a group of people to meet him, and we had the meeting together, and there were 3 other people that I invited into the meeting. Okay, so sometimes we need to get collateral history as well, and identifying. And results can take time. That's one of the problems of during the height of a pandemic. Results are delayed, and you don't want to wait until the results are out before you go and find out who that person is, who his close contact is. Okay, so if you think that somebody, the close contact, so let's say for myself, if I'm positive now, okay, and then my wife is a close contact of mine, I don't wait until her results are positive. I start finding out who were her close contacts, so that so I identify first, so that if her results come back as positive, I can straight away contact these other her close contacts to get tested. All right, notifying contacts has become actually quite a tricky task. I've home monitored a few people over this last few weeks, and and universally I found that good or bad, I think COVID has ended up carrying a stigma, almost as bad as HIV kind of stigma, so much so that people who are positive can be terrified of informing other people that they are positive, or terrified of even telling you who their close contacts are. So actually doing this job of identifying close contacts requires a lot of contact, a lot of sensitivity, a lot of reassurance that things will be kept confidential, and if I think in many countries they have they just inform the person that, look, you have been identified as a close contact for COVID. Please go and get yourself checked, and please start quarantining yourself, because they don't mention who is it that was the person who was positive. In this regard, we will you'll be working together with public health within the family. I think usually that's not a problem, disclosing the status, okay, within the household, but out of the household, we may need the help of public health, you identify the contacts and you give the list to public health. Look, this is where the patient has been, this is how long he has spent, these are some of his contacts that he recalls, this is the list, this is the contact numbers that I could get for you, and let the public health do their job. Yeah. And what happens to the secondary close contacts of the close contacts? This is where I mentioned that, if I'm positive now, what happens to my wife's colleagues? Okay, because my wife is a close contact, what happens to her colleagues? Yeah. So as I mentioned earlier, we want to identify those secondary close contacts before my wife's results come out, because that may take time. Okay, and if necessary, then we inform them as well. So this is a definition for close contacts that is in one of the infographics from Ministry of Health. I can't train you everything about how to do contact tracing, because it's actually it needs quite a bit of training if you have never done it before. And this is one of the sites that you can go through. This is CDC, and they actually have a case investigator guide, and it's several pages long, and they teach you the principles of it, how to reassure the person his privacy will be protected all the time, and at the same time getting a comprehensive history about where he has been, what he has done, and who has been in contact with that person. Okay. And for some of these patients, so we go back to the time when the symptoms started, and 2 days before his symptoms started, then we actually line list who is it that he has been in contact with and what kind of contact it is. All right. Some people they have had such active lives that they go for numerous meetings and all that, and we actually need to identify the situations that the person has been in, and who does he recall were in those areas. Finally, a couple of slides on this question also comes up for my patients who are home quarantine. What do I do with my clothing, with my linen? And these are the advice that KKM actually gives. Wash it separately from the other family members. You can use the normal soap detergents, because just as you wash your hands, that will kill the coronavirus, and so too with your common detergents that you use to wash clothes. Okay. And what you do with the tissue papers from the person who has got a runny nose, and how do you discard it? Okay. And what happens? How do you clean the surfaces, and how do you clean the toilets and all that? Basically, you actually use this dilute Clorox, and all of that can be done. You either use that, or you can use alcohol wipes as well. Okay. With that, I come to an end. These infographics, by the way, they are all found in the Ministry of Health website, and they've got actually tons of infographics over there, which can be given to the patient, and where all of us can actually learn a lot from as well. Thank you.
Thank you very much, Dr. Sin, for a very comprehensive talk on this COVID-19 assessment. Identifying and advising close contacts, which are very, very important. And like what you say, It's very simple, but it's very difficult and also very, very relevant in GP practice, especially for us advising our patients. Okay. Now, the last two topics will be one is identifying suitable patients for home monitoring and also issuing a home surveillance order. As we all know, the Ministry of Health is considering or in the process of actually allowing the GPs to be appointed officers to issue home quarantine orders and home surveillance order, and also for the wristband, and also for possible of GPs monitoring category 1 and category 2 patients. So now we have two speakers. One is Dr. Azhar Samad, FMS from KK Shah, who will be speaking on identifying suitable patients for home monitoring. Okay, with this, over to you, Dr. Azhar.
Okay, thank you very much. Okay, I will share my screen. Hold on. I have problem sharing the screen. Can you all see my screen?
Yes, Dr. Azhar, I can see.
Okay, all right, okay. Hold on.
Dr. Azhar, you have to unmute yourself. Dr. Azhar, can you unmute yourself? Dr. Azhar, you need to unmute yourself. Okay.
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 So my topic today is home monitoring for category 1 and 2 COVID-19 patients. So I'm supposed to cover suitable patient for home monitoring and what are the suitable home environment tools that we use, and also what monitoring apps. So you must know that what are the objectives of, we call it COVID-19 Assessment Center. Currently, we are doing it at the public facility, but soon, like we said, probably we will consider for GPs to do it. So we have to identify patients who are suitable to be monitored at home. We monitor and assess patients at home using standardized tools to identify and assess patients with disease progression, to identify patients for low-risk centers or hospital admission, and to coordinate referral from health clinic to low-risk center or hospital. So who are the patients that can be monitored at home? Adults less than 60 with Cat 1 and Cat 2 mild symptoms. Because just now we have heard about the comorbidity, who are at risk, and what are the staging criteria. So adult less than 60 and below, Cat 1 and Cat 2 mild. For pediatric age group, all category 1 can be monitored at home. For category 2 mild, 2 years and above can be at home. Less than 2 years, you have to be admitted. Patients that has no comorbidities, it has been mentioned just now, obesity, all the chronic diseases, suitable caregiver, I will elaborate further, suitable home condition, and also able to adhere to SOP. So these are the categories that can be home monitored. So what does it mean by suitable caregiver? Why do you need a caregiver for them? Because this caregiver, they help patients to follow instructions for self-care. They ensure patients to have healthy meals, stay hydrated, and get sufficient rest. They also act to clean and disinfect areas frequently used or touched by the patient. And they also help to call any center for consultation or even 999 if patient's condition deteriorates. So here I'll be using CAC, which means COVID-19 Assessment Center, who is monitoring the patient. So parents or caregivers should observe strict hygiene practices to avoid becoming infected when they take care of the sick patient. So who should not be a caregiver? Just now we say suitable caregiver. So it's easier to say who should not be a caregiver. Adults over 60 years of age, pregnant women, patients with comorbidities, example, CKDs, chronic respiratory disease, uncontrolled diabetes, serious heart disease, and so on, immunocompromised persons, including those who have had transplants of a solid organ, and people with other diseases considered as high risk by healthcare personnel. Now, let's see, what does it mean by a suitable home condition? They should always have access to telephone. Having a smartphone is even better, but if they only have a landline, is sufficient already. Patient is able to adhere to home isolation, where they have a separate bedroom, well-ventilated rooms, preferably with attached bathroom. Occupants in the house are not immunosuppressed, suitable caregivers are present, preparation of patients' room for isolation at home are made available, and they have a personal transport so that they can bring patient from home to clinic or hospital. Best to avoid using public transport. What does it mean to adhere to SOPs? During home isolation, patients should be able to stay at home. Patients should be able to maintain physical distance with other house members. They limit their movements in the house and avoid visitors. They should comply with basic preventive measures, example, wear a mask, regular hand washing, practice cough ethics, and they have to report their health status to healthcare providers through MySejahtera or by phone calls. And to separate the eating utensils, tableware like fork, knife, plate, and towels for their personal use. So this is a good infographic, how to prepare the patient's room for isolation. If there's no room available for exclusive use, place a bed or mattress for the exclusive use of the patient as far as possible from the rest of the family at a minimum distance of 3 to 6 feet. Patient's room ideally they should have its own bathroom. But if this is not possible, the patient may use a common bathroom, but it should be disinfected with the diluted Clorox after each use. Set aside eating utensils and tableware separately for the patients. This item may be washed with dishwasher soap. Keep the room and home ventilated, open the windows, do not shake out clothing, change and wash bedding daily, and disinfect frequently the touch areas like the doorknobs, the switches, the bed table, remote control, and etc. So if the patient is allowed to have a company, probably they need assistance once in a while, the caregiver should follow recommended biosafety measures. They should wear masks and practice hand hygiene, limit the number of caregivers who can go inside the room. The caregiver should be a family member who is healthy, young, and free from chronic illness. The caregiver should use a mask when in the same room as the patient or when at a distance of less than 2 meters from the patient. So let's go to the algorithm. So what happened in the real scenario? The district health office usually notify the patient if the patient is positive, but now the patient can be actually notified also by MySejahtera. So the district health office will do the initial triaging, notify patient, and patient will be assigned to a COVID assessment center where they will do secondary triaging. And then they will be triaged by phone or initial triaging usually by phone, then secondary triaging where they have a physical meet and they will be staged there, whether they are category 1 or mild, 2 mild, and the rest. And I can't put a yellow box here because the yellow and green, yellow and red is sometimes overlapping. So it's difficult to decide. But according to our guideline, only Cat 1 and Cat 2 mild is allowed for home monitoring. The rest should be admitted, whether to a hospital or to a low-risk center. So what happens at home monitoring? If there are worsening of symptoms, they would be admitted, and if there's no worsening, they'll be discharged after completion of home isolation. So if we see what happens here at the initial triaging, they will verify details, location, contact, number. The verifier will ask them age, identify comorbids, assess symptoms using the questionnaire, and the decision can be made there itself. If the patient has moderate symptoms, they'll be admitted. Or the other option is to give appointment date to attend the CAC. Patient will also be provided with the CAC phone number so that they can call if they have problems. And at certain places, the initial triaging is at the place of the physical examination. So they can provide a wristband and issue home isolation order straight away. What happens at the secondary triaging? So over there, that is usually done by the clinical team. The initial triaging is from the district health office team. So at secondary triaging, they will monitor, they will examine the patient. This is the first encounter. So vital signs will be checked, the blood pressure, temperature, pulse rate, SpO2. They use a clocking sheet. And then they decide whether the patient is category 1 or category 2 mild. Arrange admission if required, issue MC if required, and also at that particular time and moment, they can also issue the home isolation order or the wristband. So if you note here, sometimes there may be overlapping of activities by the district health office and the CAC home monitoring team. It depends, because some places where the burden is low, they can do it at the clinic kesihatan itself, but at high burden area, like in Selangor, for instance, many districts, they're doing it at a large space. They use community halls and also stadiums for this matter. So what happened? So what happened actually at home monitoring? Right, the activities there at home monitoring, they use monitor MySejahtera daily. They call patients and assess patients using questionnaires. They manage the hotlines, because the hotline sometimes they call, sometimes they're using Telegram or WhatsApp, and they arrange admission on the feedback that they got from the patient. And they also provide feedback and data to the district health office. So at the CAC or COVID Assessment Center, there are two main activities. There are the clinical assessment where they meet the patient and assess the patient. The other component is the case manager where they monitor the patient through phone calls. What happens on the discharge day? So at day 11, or at least 10 days have passed since the symptoms onset, the patient will come again to the CAC. They will have their release order, and also their wristband will be removed, and if they require MC, it will be issued there. So this is also done at the CAC. So the CAC, the clinical assessment, case managers, and also discharge. So this is an example of the clocking sheet used. Okay, this is the salient points that needs to be there. Some places use Google form, but with the items, all details inside. It depends on each places. So this is a generic clocking sheet. Okay. Home monitoring, this is what I want to emphasize. So what tools do we use? What apps do we use? And how is the process of home monitoring? We have seen just now, patient on home monitor, we need tools. So what tools do we use? So if you see a patient on home monitoring, when we have seen the patient at first instance and they are suitable for home monitoring, we will give the patient a home assessment tool. There are two for adult and also for pediatric. Okay, so they go back, right? They go back, and we call them. If they have symptoms, if they have no symptoms, they continue home monitoring. They only come back when they have symptoms or at day 11 for release. If they have symptoms, what do we do? So healthcare provider will use adult COVID home assessment tool, or ACOHED, or pediatric COVID-19 home assessment tool, PCOHED, for monitoring. We have heard just now from Dr. Wong how we triage a patient using the phone call. So I'll share with you after what forms do we use. So this is what happened at home monitoring or case managers. They will call the patient, assess using the A cohort or P cohort. If the patient is mild, get too mild, they can continue home monitoring. But if the patients get too moderate or have danger signs, they have to decide here whether the patient needs urgent referral or not. That's why you have to really master the home monitoring using the phone. If they need urgent referral, refer straight away. If they do need urgent referral based on our triaging through phone, we can ask them to come to CAC and assess. So if they have worsening of symptoms, admit. If they don't, we continue home monitoring. Okay, these are the home assessment tool for adult patients. So they have fever, sore throat. So the patients would answer this and monitor for 10 days. And this is also available in MySejahtera. I'll show it later. And this is for the pediatric patients. The caregiver would monitor the symptoms for the child. This is the A cohort for the healthcare provider. So if you call the patients, the adult patients, and you see they have 1 to 9, so this is mild symptoms. All right, so patient have mild symptoms and they can be referred to CAC. If you're worried, ask them to come back and assess. But if they have symptoms at 10 to 18, that's a warning sign and maybe they need referrals to hospital for further assessment. This is for adult. Same thing goes for pediatric. If they have, this is the P cohort. If they have symptoms 1 to 3, this is mild. We can ask them to come and we assess again. But if they have symptoms at 4 to 14, which are the warning signs, then they moderate signs and warning signs, they need referral to hospital for further assessment. So how do we do this actually, right? So what apps do we use? Fortunate for us, we have MySejahtera. So actually MySejahtera, many of us just use it to screen when you want to enter or you want to see what are the hotspots of COVID. But actually this is not my slide. This is a slide from the MySejahtera team. Acknowledgement to Dr. Mahesh and MySejahtera team. So they can do self-reporting, right? So when patient can actually, if you go to the help desk at MySejahtera, Mula, then they can identify or notify MySejahtera that they have been sahkan COVID positive and waiting for calls from KKM. We heard that there are many complaints that positive people have not been called yet, so they can notify at MySejahtera. And what else can MySejahtera do? They can do also the monitoring of the home management, patient management. When they have notified themselves as COVID patient, they will get a message that they have been confirmed to be COVID positive. And then they will receive a page like this. And they can put it their symptoms, sejarah perubatan, whether they have comorbids or not. And they can upload their medical history here. Adakah mempunyai penyakit? And these are the symptoms that we ask them to answer. So they have to answer this every day at 9 a.m. Every day. So MySejahtera will actually filter the data and give it to the CAC or also or to PKD. So this will then be looked after by the case managers. Patient who has no symptoms, never mind, we can just leave it. But patient who has symptoms, you have to call them. So this is how it works. But maybe some other places would have another way, maybe a Google Sheet to monitor. It's okay as long as what we monitor is the same, are the same symptoms that we want to know. So what happens? Patient has completed home monitoring. If patient remains asymptomatic till day 10 after the date of their first positive test, or at least 10 days have passed since onset of illness. So what do we do when during the release day at day 11? We assess a patient, stable vital signs, no hypoxia, stable or controlled comorbid. If they have some blood tests, we can see whether it's normal. But most of the time, patient on home monitoring, they don't have any blood investigations. They are able to ambulate without assistance and self-administer medication and do not have ongoing clinical needs such as hemodialysis. So they attend CAC at day 11, assessed, get a release order, get MC if required, and remove their isolation wristband. A repeat PCR test is not required before discharge from home monitoring. So summary of the presentation, what do you do when patient comes for adult patient, diagnose COVID-19, you see whether they are pregnant or not, whether they have comorbid. If they have, admit. If they don't have, they can see the home suitability, not suitable, admit. If they are aged more than 60, admit. If they are less than 60, but has more than Cat 2, admit the patients. If not, they can be assessed at the CAC or home monitoring. Same thing for pediatric, diagnose COVID-19, any comorbid, no suitable home center, carer, yes, home environment, suitable, and see what's the category, and then you see if Cat 1, all ages can go for home monitoring, Cat 2 mild, less than 2 years goes in the hospital. So what are the function of CAC or COVID Assessment Center? We monitor patients' condition daily through telephone or virtual. Using patients, we use adult or pediatric home assessment tool. Healthcare provider use the A cohort and P cohort where they go deeper into the questions, assess patients with symptoms and determine if there's need for admission, discuss with physician in charge on admission or for the management of the patient, arrange for admission of patients when needed, provide feedback to district health office on the outcome of the patient, evaluate and discharge patients who has completed the home isolation period, arrange home visit if necessary, and contact tracing by the assistant environmental health officer or if he or she is stationed in CAC. Okay, that's all. Thank you.
Thank you, Dr. Azhar. I think this is the first time VGPs are also having a comprehensive overview of the identify suitable patients for home monitoring. Thank you again.
Right.
Lots of information and lots of questions our doctors have posted. Later, Dr. Siva will ask all these questions. Okay, and then for the last speaker is Dr. Rohani Jahiz. She's the Crypto Sector for BKPD from KKM. And then she will be speaking on issuing home surveillance order. And then now over to you, Dr. Rohani.
Thank you, Dr. Arasu. Can I share my slide now?
Sure, Doctor. You can do the slideshow.
Okay. Right. Let me find it. Okay. All right. Basically, as mentioned by Dr. Noazar, we are going to give peranan and penglibatan pengamal perubatan swasta dalam pengendalian pandemik COVID to assist Ministry of Health, because as you already know that MOH is overwhelmed with the current number of cases and also the context. So penglibatan pengamal perubatan dalam memantau ataupun memantau kes-kes positif COVID adalah berdasarkan kepada ordinan darurat yang telah diumumkan oleh Duli Yang Maha Mulia Agong pada 11 Januari. So di bawah ordinan tersebut dinyatakan di bawah Seksyen 61 bahawa kita boleh mengeluarkan pengamal perubatan berdaftar yang berkhidmat di fasiliti kesihatan swasta yang diturunkan kuasa di bawah Seksyen 61 Ordinan Darurat Kuasa-Kuasa Perlu 2021 dalam mengeluarkan arahan bagi rawatan, imunisasi, pengasingan, pemerhatian atau pengawasan di bawah perenggan 11.3A dan B Akta Pencegahan dan Pengawalan Penyakit Berjangkit 1988. Basically, pengamal perubatan swasta akan diberi kuasa bagi menjalankan aktiviti-aktiviti yang selama ini dijalankan oleh pegawai diberi kuasa di bawah Akta 342 yang terdiri daripada pengkhidmat awam. Sama ada doktor, PPKP, pegawai kesihatan persekitaran atau penolong pegawai persekitaran yang diberi kuasa di bawah akta tersebut. So bagi memudahkan pihak kementerian menguruskan pewartaan tersebut ataupun pemberian kuasa tersebut, kita memerlukan senarai pengamal perubatan swasta yang hendak bekerjasama membantu KKM. Segi nama, nombor MMC, nombor telefon dan alamat tempat amalan. So sebagaimana kita telah disarankan semasa mendaftar sesi ini, Dr. Arasu dan pihak MMA telah memohon maklumat-maklumat ini dan juga tanyakan sama ada semua tuan-tuan dan puan-puan berminat untuk membantu KKM dalam melaksanakan perintah kawalan, perintah pengawasan dan pemerhatian di rumah. Okay, so next, okay, sorry. How do I control? Next slide. So objektif bagi membawa GPs ke dalam memberi perkhidmatan tersebut ialah bagi mengoptimalkan penjagaan kes positif COVID-19 di rumah masa jalankan kuarantin serta melakukan notifikasi dan advokasi yang mana saya pasti tuan-tuan dan puan-puan sedia maklum dan telah melakukannya bagi membantu mengawal penularan COVID-19 di Malaysia. So pertama, dalam penglibatan pengamal perubatan swasta, kita hendak melibatkannya, meningkatkan penglibatannya dalam pengurusan kes positif. Kes positif, kita fokus pada kes positif dulu, di mana GPs boleh mengeluarkan surat perintah pengawasan dan pemerhatian di rumah dan memakaikan gelang pengawasan di bawah Seksyen 61 Ordinan Darurat dan boleh mengenal pasti kontak rapat dan menasihatkan mereka sama ada datang ke klinik tuan-puan ataupun pergi ke CAC berdekatan untuk dilakukan penilaian risiko kesihatan. Dan ini yang penting, melakukan tindak susul kes positif secara harian menggunakan kaedah telekonsultasi dan pada akhir tempoh pengawasan dan pemerhatian di rumah, tuan-puan diminta untuk memotong gelang dan mengeluarkan surat pelepasan kuarantin setelah tamat tempoh kuarantin. Selain itu, semasa follow up dalam tempoh 10 hari tersebut, sekiranya terdapat keperluan untuk merujuk kes ke hospital ataupun ke CAC, maka mekanisme rujukan seperti sedia ada yang telah dilakukan hendaklah dipraktiskan. Okay. Selain daripada itu, tuan-tuan dan puan-puan juga akan dilibatkan dalam pemberian vaksin COVID yang akan diterima kelak. So itu adalah projek seterusnya selepas kita melibatkan GP dalam pemberian kuasa untuk mengeluarkan HSO. Okay. Dan daripada itu sedia ada ialah tuan-puan juga adalah sebagai rakan strategi KKM dalam menyampaikan maklumat berkaitan pencegahan dan kawalan COVID-19 kepada pesakit yang mendapatkan rawatan di fasiliti masing-masing. So pihak CCAP sedang merancang untuk mengadakan satu sistem teknologi menggunakan ICT bagi memastikan maklumat-maklumat dapat disampaikan kepada tuan-tuan dan puan-puan dengan cepat, tepat dan bersasar kepada semua bagi tindakan sewajarnya. Okay. Ini mungkin satu projek jangka masa panjang bukan dalam masa terdekat. Okay. Jadi sebagaimana yang telah diceritakan oleh Dr. Azhar dan juga doktor-doktor yang lain kami menyarankan untuk pelaksanaan HSO bagi pengamal perubatan swasta adalah diberikan hanya kepada kes-kes kategori 1 dan 2. yang sesuai untuk diberi HSO sebagaimana yang Dr. Azhar dah terangkan dalam kriteria-kriteria tersebut. Dan kontak kepada kes positif walaupun tiada keputusan makmal demi mengengkang daripada penularan COVID dalam komuniti. Walaupun pesakit yang tidak layak diberi HSO dan gelar pengawasan ialah mereka yang menjalani saringan tempat kerja dan kes tiada gejala dan tiada kontak dengan kes positif. Sebenarnya yang tuan-tuan dan puan-puan sedia maklum, sebahagian daripada GP merupakan panel bagi industri ataupun tempat kerja tertentu ya. Jadi sekiranya pekerja daripada tempat-tempat tersebut melakukan saringan rutin, maka mereka juga tidak perlu diberi HSO dan gelang pengawasan. Okay. Selain daripada itu, kes positif COVID-19 yang memerlukan rujukan ke hospital, maka dia tidak perlu diberi HSO dan juga gelang pengawasan. Dan apabila rujukan dilakukan, ia hendaklah dimaklumkan kepada PKD berhampiran supaya pesakit yang enggan ke hospital dapat dibuat tindak susul oleh pihak pejabat kesihatan daerah. Okay, ini adalah carta alih pengendalian kes di klinik swasta. Apabila tuan-puan menerima pesakit, pemeriksaan akan dijalankan dan sekiranya disyaki COVID-19, tuan-puan dinasihatkan untuk mengambil nasopharyngeal swab dan sementara menunggu keputusan ujian makmal, tuan-puan dipohon untuk menasihatkan pesakit untuk tinggal di rumah dan laksanakan pengasingan sehingga dimaklumkan keputusan ujian makmal. Yang mana saya percaya tuan-puan telah melaksanakan perkara ini sejak dahulu ya. Dan arahkan pesakit untuk memantau status kesihatan sendiri dalam aplikasi MySejahtera sehingga dimaklumkan keputusan makmal. Dan sekiranya keputusan makmal positif, kita pergi negatif dulu negatif tu senang sikit, cepat habis. Sekiranya keputusan negatif, kita maklumkan kepada pesakit untuk hadir ke, kita tak bagi gelang. So sekiranya keputusan positif, kita selesai, tiada tindakan seterusnya. Sekiranya keputusan positif, keputusan tersebut adalah dimaklumkan kepada pesakit dan dapatkan kepastian sama ada pesakit hendak membuat tindak susul dengan pihak tuan-puan ataupun hendak dirujuk kepada COVID Assessment Center. Okay. Pada masa yang sama, kes hendaklah dinotifikasikan ke pejabat kesihatan berhampiran dan sistem e-notifikasi boleh digunakan bagi menotifikasi kes tersebut ataupun menggunakan panggilan telefon ataupun menggunakan borang notis yang dihantar ke pejabat kesihatan daerah. Okey, sekiranya pesakit bercadang untuk membuat tindak susul di COVID Assessment Center dan arahkanlah pesakit untuk ke CAC bagi pemantauan lanjut ya. Walaupun sekiranya pihak pesakit bercadang untuk meneruskan pemantauan di klinik tuan-puan, maka pesakit hendaklah diarahkan untuk datang klinik untuk dibuat assessment, kemudian diserahkan surat perintah pengawasan dan pemerhatian di rumah dan dipakaikan gelang pengawasan, di mana tuan-puan yang diberi kuasa untuk mengeluarkan dan menyerahkan surat perintah pengawasan ini akan diberi borang tersebut untuk diserahkan kepada pesakit. Dan pesakit tersebut hendaklah disusuli selama 10 hari sekurang-kurangnya, iaitu tempoh pengawasan melalui telekonsultasi. Dan pesakit juga hendaklah dinasihatkan untuk mengisi MySejahtera sekurang-kurangnya sekali-sekali supaya pemantauan juga dapat dilakukan di peringkat sistem ya. Okay. So dalam tempoh pengawasan sekiranya tiada warning sign, maka pada hari ke-10 borang pelepasan boleh diserahkan kepada pesakit dan gelang dipotong. Dan PKD hendaklah dimaklumkan bahawa kes tersebut telah tamat HSO. Untuk pemakluman ini boleh dibandelkan sekali bagi memudahkan tindakan tuan-puan lah. Walaupun sekiranya dalam semasa tempoh pengawasan 10 hari tersebut, pesakit menunjukkan warning sign red flags, maka kes hendaklah dirujuk ke CAC atau ke hospital untuk rawatan lanjut Pada masa yang sama, ia hendaklah dimaklumkan kepada PKD supaya pejabat kesihatan daerah boleh membuat tindak susul ke atas kes tersebut bagi memastikan dia telah pergi ke hospital. Okay. So bagi melaksanakan HSO dan juga pemakaian gelang pengawasan oleh pihak GP, ada beberapa isu dan cadangan yang perlu kita bincangkan ya. Pertama, sebagaimana kita tahu bahawa di bawah ordinan darurat terdapat seksyen yang membolehkan permintaan bagi penggunaan sumber oleh pihak swasta dan ia tertulis atau ternyata dalam seksyen 4 ordinan darurat tersebut. Di dalam ordinan tersebut ada dinyatakan bahawa yang di-Pertuan Agong yang nombor 3 tu ya, yang di-Pertuan Agong atau mana-mana orang yang diberi kuasa oleh yang di-Pertuan Agong dalam hal ordinan darurat, orang yang diberi kuasa ialah Perdana Menteri, Yang Amat Berhormat Perdana Menteri kita, boleh memberikan apa-apa arahan berhubung dengan pengenaan apa-apa fee atau charge yang boleh dikenakan oleh orang yang sumbernya diminta di bawah subsection 2, iaitu yang di 4.2 di atas lah, yang di-Pertuan Agong atau mana-mana orang yang diberi kuasa oleh Pertuan Agong boleh memberikan apa-apa arahan berhubung dengan penggunaan, pengurusan dan kawalan sumber kepada orang yang sumbernya diminta. Berhubungan dengan itu, Jemaah Menteri telah mengarahkan, Perdana Menteri telah mengarahkan untuk ditetapkan charge bagi ujian makmal pengesanan COVID. So KKM telah mencadangkan untuk charge bagi ujian makmal ini diselarikan dengan charge kadar yang dikenakan di bawah peraturan-peraturan pencegahan dan pengawalan penyakit berjangkit, fee bagi ujian pengesanan penyakit coronavirus 2020, di mana dalam jadual jadual tersebut dinyatakan bahawa bagi ujian PCR bagi warga negara dia kosnya adalah RM150, manakala bagi warga asing RM250. Manakala RTK antigen RM60 bagi warga negara dan RM120 bagi bukan warga negara, dan RTK antibody RM30. Di mana kita tak gunakan RTK antibody, kita fokus pada PCR dan RTK antigen sahaja. Dan kos ini akan dibayar oleh pesakit yang memohon untuk dijalankan ujian tersebut. So itu adalah satu charge yang kita selarikan bagi semua fasiliti kesihatan swasta. Selain daripada itu, bagi pemantau kes-kes di rumah, kes-kes yang diletakkan kuarantin ataupun pengawasan dan pemantauan di rumah, dicadangkan untuk telekonsultasi yang dilakukan oleh pihak tuan-puan, kadar RM10 per pesakit sehari untuk sehari sehingga tamat tempoh HSO tersebut, dan reimbursement akan dibuat kepada kerajaan ke atas setiap pesakit yang dipantau, dan tuntutan bagi lain-lain perkara yang tidak berkaitan dengan COVID hendaklah ditanggung sendiri oleh pesakit tersebut. So mekanisme akan diperincikan dan akan dikongsikan dengan tuan-puan kelak. Selain daripada itu, bagi rujukan kes, pesakit yang disyaki dan disarankan untuk menjalani ujian pengesanan COVID-19 oleh pengambil perubatan tapi tidak mampu membuat bayaran bagi ujian tersebut, diminta untuk dirujuk ke klinik kesihatan kerajaan. Kriteria untuk disyaki sebab bila seorang individu pergi ke klinik kesihatan untuk memohon ujian makmal pengesanan COVID tanpa sebarang indikator, mereka perlu membayar kos bagi saringan tersebut. Tapi sekiranya dia disyaki, iaitu mereka yang bergejala, mereka yang disahkan kontak rapat kepada kes positif atau mereka yang berisiko tinggi, sekiranya dirujuk ke klinik kesihatan, mereka akan dibuat ujian tanpa sebarang bayaran atau kos ujian. So kita mencadangkan sekiranya kes-kes yang memenuhi kriteria-kriteria tersebut dirujuk ke klinik kesihatan terdekat menggunakan mekanisme sedia ada yang rujukan kes semasa. Selain daripada itu, saya dimaklumkan bahawa terdapat isu-isu yang berkaitan dengan pelaksanaan Akta 342. So kita telah menyediakan satu talian bagi menjawab sekarang isu-isu berkaitan. Kita tahu bahawa pihak penguatkuasa kita di lapangan overwhelmed dengan penyiasatan kes dan kontak di lapangan. So kita akan cuba memudah cara membantu tuan-tuan bagi menyelesaikan isu-isu berkaitan dengan Akta 342. So selain daripada itu, saya juga tadi nampak bahawa terdapat isu-isu ataupun pertanyaan mengenai dedicated kepada siapa perlu dirujuk kes. So tuan-tuan boleh merujuk kes ke CAC atau bagi Lembah Kelang boleh dirujuk kepada Unified Command Center atau UCC. Okay, saya rasa itu saja daripada saya. Terima kasih.
Thank you, Dr. Rohani, for the talk on the issue of home surveillance order, and I think it is very exciting and welcomed by the GPs. But at the same time, we have also received some shocking announcement from the last two slides, especially on the costing. But never mind. What we will do is that now we will proceed to Q&A, and then Dr. Siva will start asking the questions from all the speakers. We hope all the speakers are here. Otherwise, Dr. Ben can actually coordinate on that part. And then on the part of the implementation, I will be asking a few questions on that part. Dr. Siva?
Yeah. Thank you. I hope you can hear me now. Since Dr. Rohani just completed the lecture, I have one question for her.
Yes.
Dr. Rohani, you say most of the patients walking in the clinic, they are doing RTK and Adhere.
Okay.
You know, if it's positive, most of the time you have to proceed to PCR to confirm the case.
Yes.
But unfortunately, most of the doctors, they are not willing to do the PCR in the clinic because of cost issues and all. So can these patients directly be referred to clinical kesihatan?
Yes, because they are RTK antigen positive and we need to confirm for further action. So you can refer those cases to clinic kesihatan.
Okay, thank you.
For in Selangor and also in Sabah, prevalence of COVID is very high, more than 10%. We take RTK antigen as positive. So for those cases with positive RTK antigen, they are considered as COVID case and do not require PCR.
Okay, let's go for the other question from the beginning. I hope all the other speakers are with us now. One of the frequently asked questions in the chat group was, can NSAID, non-steroidal anti-inflammatory drugs, safely be used in COVID-19? Can somebody answer?
Dr. Ben or Dr. Gan or Dr. Wong?
Dr. Ben, are you with us?
Hi,
Sorry.
I think, yeah.
Yeah, Puili, you want to go ahead?
Yeah, sure. I think for NSAIDs, the WHO hasn't issued any contraindication to NSAIDs for adults, but I think in the pediatric population that it is contraindicated for NSAIDs.
As a physician, I rarely prescribe NSAID as well. But as I was preparing for the talk, it is listed as one of the commonly prescribed, self-remedy medications under the NHS GP for adults. Our PEDS colleague has rightly reminded us as well that NSAIDs should be avoided for PEDS due to its common side effects, etc. Likewise, we were reminded as well we should be mindful about dengue, and generally we should actually avoid NSAIDs as well.
Thank you. Our next question. Can vibramycin used as a prophylaxis for accidental exposure to COVID-19 patient?
That is a very interesting question. I have no answer for the question. I hope there is data for it to actually recommend the use as a prophylaxis. I'm not aware of any antimicrobial that has data as a prophylaxis against COVID-19 infection.
Any other opinions?
I'm in agreement with Dr. Gan as well. I don't think that there is evidence or strong enough evidence to suggest prophylaxis with that for the time being.
Another frequently asked question. Dr. Ben, you mentioned about the exit test on day 9 or day 9 or 10. What test do you really recommend here if you're supposed to do one? Dr. Ben? Everything okay? Any other speakers?
Can you repeat the question, please?
Okay. You mentioned that you do exit test for the once you're completing day 10. What test do you recommend?
I'm not quite sure in what context Dr. Ben was referring to. Okay, let's put it this way. So ideally, the quarantine period, the purpose of the quarantine is to reduce onward transmission to other people. That's the whole purpose of the quarantine. So a 14 days quarantine has 100% efficacy against onward transmission if the infected person completed and completely adhere to the 14 days quarantine. So the issue now is we're trying to strike a balance between unnecessary prolonged quarantine and we've returned to work, for example, or return to normalcy post-quarantine for activities of daily life. So that is why CDC actually has a good article that actually the smart people came around and discussed with regards to the evidence and science behind it, and they sort of gave recommendations to how to actually safely end the quarantine. In one of my earlier slides, which I mentioned, which I also used it for FMS teaching previously, that CDC gave an option to end quarantine at day 10, post-exposure, if the person is completely asymptomatic within the 10 days and also remain well, there is no need for testing. And I think Dr. Ben also mentioned it. However, if you would like to actually do a test, ideally you would like to get a test result before the end of the quarantine. So now it depends on how fast you can get the test result. Generally, we actually take about 48 hours for PCR testing. So we will recommend you to actually do a PCR at day 8. If you can do it on day 9, you can get the result before the end of the quarantine, is also acceptable. As for RTK antigen, it's not very useful if the person remains asymptomatic towards the end of the quarantine, because RTK antigen correlates with early viral infection phase when the virus is actively replicating. So if the person remains asymptomatic towards the end of day 10 with no new exposure, RTK antigen is not that helpful.
Thank you, Dr. Gan. Another question asked here is that on day 10, a patient, COVID positive patient discharged after day 10, but the CT is still less than 25. What shall we do here?
Okay. If I get the question correctly, number one, we don't routinely repeat PCR anymore before discharge. So that PCR, I'm not sure whether we are repeating PCR and we have a new CT value, or that was initial PCR result which was obtained before discharge. So if the patient remains well and was discharged, we don't repeat PCR. That's the current standard of practice at the moment. So I actually don't quite understand the question. So if you repeated a PCR and the CT value is less than 25, so there is variation between labs for PCR results. I have personally seen many results which were repeated in the community post-discharge, and they were re-admitted. And when we repeated the PCR, it's actually very different. So it is well known that there can be inter-lab variability up to 14 cycle threshold. Even between the same lab, there can be some variation as well. So if the patient remains well post-discharge, we won't repeat the PCR and we won't look at the CT value.
Thank you. Now, there's a question. I think this is for the final speaker just now, Dr. Rohini. The question says, this is about remuneration for the JPs who are doing the counseling. It is only fair to allow GPs to charge RM35 for tele-consultation. The reason is because the 7th schedule allows doctors to charge 10 to 35 ringgit. A typical consultation takes 10 to 15 minutes. However, the family members or even the patients will be calling the clinics as they might have some mental anguish. So paying RM35 per section is very reasonable and fair compared to the workload which we are taking, and also providing monitoring and continuous care. That's can we have some opinions from you, Dr. Rohini?
Thank you, Doctor. Maybe I would like to request my director, Dr. Noyati, to reply to this question.
Is she with us today?
Yes.
Okay.
Please, Dato'. Thank you.
Doctor, we are waiting for your answer, Doctor. Are you with us? Dr. Rohini, we are not getting any answers so far. Dr. Maria Sulaiman, can you unmute?
Maybe we'll go on to the next question.
Okay.
Dr. Maria.
Oh, okay. Okay. All right. Okay. Thanks. Will you please unmute Dr. Maria Sulaiman?
She has to unmute herself there.
Okay. Dr. Maria, please unmute yourself.
Okay, while waiting, can I go to another question? Okay, while we are waiting, I'll just go to the next question. What is the significance of antibody investigation, especially the IgG? Because there's a request from certain countries before they travel, they have to do IgG. Anyone like to answer the question?
Sorry, I'll just take that question. I think IgG for managing an individual who is before us at this point, actually there's actually no real benefit now, because the antibodies come up at least 2 weeks after infection, by which time most patients would have recovered already. I think it's mainly useful for seroprevalence studies, for studies into whether vaccines have worked, for studies into whether the patient has had past infection or not. But for present infection, when the patient comes to us, there's actually no value in it for clinical management.
Thanks for answer. Dr. Rohini, is the boss there?
Yeah, Dr. Asu, I'm here. Yeah, very good evening to everyone. I'm Dr. Nurhayati Lusli from Discount Television. I think the question that we asked just now, that's a very interesting question. I think we do understand that the charge that that Dr. Hani briefed everyone just now, very minimum. I think I saw all the feedback from the chat there. I think most of you are not agreed with the proposal with 10 ringgit a day. Maybe I would like to bring you back to the guidelines or the flowchart that have been presented by Dr. Rani as well as Dr. Azhar this evening. Because now, just imagine in one situation where you have one case, for example, one case detected as positive COVID-19. It can be through RTK antigen or RT-PCR. So once you detect this case as positive COVID-19, if, for example, you do RTK antigen and this patient won't agree for you to test for RT-PCR, I think maybe because of the cost of that. So I would like to clear that one. First of all, what if you detected this case positive through RTK antigen, and then he or she won't allow you to proceed with RT-PCR? What you can do is in the future, once you get the kuasa atau pegawai di kuasa as been mentioned by Dr. Ran just now, so what you can do is you can issue HSO at your level, as well as wearing them with wristband. This is one of the things that the government would like actually for the GPs to collaborate with us, you as our partner, to be as the pegawai berkuasa during the darurat. Where you will be given the power by the Amat Berhormat Presiden Malaysia, as mentioned by Dr. Anis now. Once you have that power, that means you will be the pegawai berkuasa, then you can issue the HSO. That means perintah pemantauan dan juga pengawasan dan juga pengawasan di rumah. Then and as well you allowed to give them wristband. I think you know about the wristband, the pink, even a white color and so on, this wristband. And this patient will be monitored at home. What I'm trying to tell you is that once you detected this case as positive and you categorize them as Cat 1, Category 1 and Category 2, as been mentioned by Dr. Azhar just now, this case can be monitored at home. So for this case, what you can do is that if you have been given sebagai pegawai berkuasa, then you can issue the HSO and wear them with the wristband, and you can send them home where they will be monitored by you, or if they don't want to be monitored by the GPs, they can be monitored by us from CAC or through MySejahtera. But now, what we are trying to brief you this afternoon or this evening, because we are really hoping that more GPs will collaborate with us to assist us in monitoring these Cat 1 and Cat 2 cases at home, because we are quite burdened with the cases, increase in number of a lot of cases, especially at Klang Valley areas, where we have more than 1,000 cases a day. For example, in Selangor, they reported more than 1,000 a day. Just imagine we have only 6 PKDs or 6 daerah and few PKDs that can man this case. At the same time, they are also the same team. They need to go to the house to do contact tracing, investigation, all that. So now this is the best time where we need more collaboration from GPs so that you can monitor this Cat 1 and Cat 2 at home until completed 10 days. The charge that been mentioned by Dr. just now is talking about the daily monitoring, not the first time where you did the test, you examine them on daily physical, on daily basis. But it's talking about the monitoring, daily monitoring part of it, where if they are monitoring at home, usually they will monitor, for example, Cat 1 and Cat 2. If we allow them to be monitored at home, or isolate them at home, usually we'll monitor them through MySejahtera. They will monitor their health status through MySejahtera or through CAC, as been mentioned or briefed by Dr. Azhar just now. So on that part, Dr. Rani is trying to tell everyone here, the 10 ringgit daily charge is only for that monitoring part, or daily part, not the first part, or when they come to you for different situation or different illness. But then talking about the monitoring part, where you be given 10 ringgit a day for 10 days for 100 ringgit, a blanket for 10 days. But then in between, if they have other condition, for example, heart problem or that, and they need to be treated, seen by you because of other illness, then that one it can be different charge according to your service charge as routine. So that one really on monitoring part of it until completed 10 days. On the day 10, where this patient need to be released under that Perintah HSO, so you are also allowed to issue a release order for them and cut the wristband. So this talking about the monitoring of this Cat 1 or Cat 2 at home, because Cat 1, they are asymptomatic and they are stable. Cat 2, very mild illness where you can monitor them at home. But then if they turn up as Cat 3, 4 or 5, they need to be referred to nearest PKRC or hospital. So that's the thing that talking about the 10 ringgit is now. I know maybe if you monitor them through calling them on daily basis, I'm also sure, I think the telephone charge may be less than 10 ringgit, but it's really talking about the daily monitoring on that part. So maybe you can start discuss on that. I know a lot of comments from the chat board just now, not agree with 10 days a day, and for 10 days monitoring 100 Malaysian ringgit. But then maybe we can still discuss on this charge part of it. But are you willing? Are you willing to see these cases and issue them the HSO and wristband, and send them back as Cat 1 or Cat 2 at home for home monitoring? That's one portion part of it. The second one talking about the daily monitoring. After you put them under HSO and wristband, they will monitor on daily basis for 10 days. That one is for talking about 10 ringgit a day for 10 days until the end of the day, end of the 10 days, completed 10 days, then you need to issue a release order as well as to cut the wristband. So we are hoping that you can agree with the package. That means instead of you screen them as a positive case, but you are also monitoring them as Cat 1 or Cat 2 at home, where you can issue the HSO, the quarantine order, and wear them with the wristband. And finally, after complete 10 days, you can issue release order and cut the wristband. So maybe you can discuss on this part, Dr. Alsu and everyone here. Thank you.
I think we in MMA, as well as you can see the chart there, there is lots of disagreement about the $10 the notoriety.
Yeah,
but
yeah.
Our HTS will answer the question, some questions.
Yeah, Dato, thank you, Dato, for the explanation. Okay, basically, we have sent out yesterday 1,000 odd GPs. I assume that they have responded whether they're willing to participate or not. Of course, many of them are willing to participate without looking into the pricing. Okay, I think in terms of giving HSO or wristband, I think many are willing to participate. But on the daily monitoring, to be fair to the profession, in fact, if our fellow colleagues from Ministry of Health, big doctors, and advising the government for 10 ringgit is actually an insult to the private sector. I'm very sorry for being blunt. I think it's an insult to the private sector. And then as the Honorable General Secretary, I think MMA will not accept the 10 ringgit. But of course, we are also worried if emergency ordinance will be used against us. There is another issue. And I think it has to be a fair figure. It is not only a questionnaire. If the ministry wants our staff to do the questionnaire, maybe some might consider. But then the ministry must also make sure that there's no medical legal implications if anything were to go wrong to the patients. So there are a few things to be discussed, and we hope that the ministry will engage MMA with our fellow medical associations to get more feedbacks. I think the other day I did brief all the challenges, the real challenges. SOPs may look very nice, but when we really implement on the ground, to be fair to the GPs, many of us who are doing the testing, we know the real challenges on the ground. The SOPs only look nice on the papers, but on the ground, we face the patients on a daily basis, their family members on a daily basis. And the moment it is positive, they will keep on calling the clinic until the patient is taken to the hospital. That is the current scenario. These are the real things that we go through. So we hope that the ministry will call for a immediate meeting on these so that we can move forward and then for a fair rate for the GPs. That's one thing, Dato. And the other thing, Dato, we were also shocked when we saw the rate for the testing. What we noticed is that the ministry is very much wanted to regulate the practitioners. So what about the test kits? Can the ministry regulate the test kits, the labs? For example, a lab for RT-PCR, a lab cost can be as low as 120 if you do bulk screening. But if you're talking about those walk-in patients, an average cost for a GP, only the lab cost is anything between 140 to even 230 ringgit, depending on the regions. Sabah could be very high, Sarawak could be very high, outside Klang Valley is quite high. Maybe in Klang Valley, maybe anything between 140 to 180. So that is the rate that we're looking at. So by asking the GPs to charge 150, I think many GPs should stop doing the RT-PCR. I think that's what I see. And then if you're looking at the RTK antigen, the cost itself can go from 38 ringgit to 45, 46 ringgit. And then if you're asking the GPs to do a RTK antigen for 60 ringgit, I think again, from the data from Malaysian Medical Association, we have estimated that in the month of January alone, 100,000 RTK antigens were done by the GPs, with another 100,000 RT-PCRs were done by the GPs. I think with this rate, I think the GPs will actually stop doing the test, and it is actually a loss to the government because if you're talking about pick-up rate of 2 to 3%, then we are talking about at least from 200,000, we are talking about at least from 8,000 to 12,000 patients that GPs are picking up. So this will be a loss. When these patients are going out and start infecting the others, the government is going to spend more money in managing them. Our economy is going down. So we hope that all these things will be considered. And the only thing we can do is that we hope that we can bring it up to the highest level and then to have another meeting to discuss further on this. Thank you.
Thank you very much, Dr. Asu. I think well said by everyone. I think as been discussed earlier, we did engage with you earlier. I know. I think it's a big decision for the MMAs decide whether you agree or not. But then for sure, I will bring it back to the high level. But regarding the lab test, I think the charge or the rate has been controlled at that amount after I think certain search by the lab team from the KKM lab team. So by the way, I will bring up this matter again to high level regarding the lab test. Regarding the 10 ringgit a day, for sure, because now we're throwing the ideas just to get feedback from the MMAs. But then I was also informed that if less than 35, what is the minimum cost that we will be, you would like to offer for this collaboration for monitoring of the case? Just now, most of you did mention about the 35 ringgit a day. How about less than that? What is the minimum you can be offered to us? Dr. Asu and maybe one there. Someone did mention there 35 ringgit a day.
Yeah, so probably you give us one day, let us put we get collectively from the various associations and right back to the ministry. If it's okay with you.
Yeah, okay, for sure. And then one more thing, Dr. Asu, if you propose that just now that certain certain level of amount of cost, can you just list down from which that amount of cost that we like to offer? What is the list of tasks that you can do? At least I can explain to high level that with this range of cost or rate, 35 ringgit or 25 ringgit is now, it's for this task for GPs to do. I think hopefully you can come up with that proposal as well, Dr. Asu.
Sure, Doctor, we'll do that.
Okay, thank you. Thank you.
Thank you, Dr. Hadi. Yeah, thank you, Doctor. We'll go to the next question. This is a question asked for one of the what we see in practice daily. if somebody has been positive and being home quarantined for 10 days, and after 10 days, they come back to us requesting for medical leave, how long do we give? Or do we have the right to give longer holidays?
I'll take that question. There are two reasons for a patient being hospitalized or being ill. One, in this case, one is the patient's health, and the other is the risk of infection, them infecting other people. So we are saying for mild disease, there's no longer any risk beyond 10 days. But for the clinical health itself, they may warrant a longer MC. As it is still I know it's been around for 1 year, but it's still a fairly new disease to us. And I think Dr. Gan did introduce the whole term of long COVID. I think it's known in the popular press as long COVID, and apparently up till 10% of patients actually with mild disease actually go on to get long COVID, where they can, it's just like dengue as well. I know not everybody recovers in 1 week in dengue. Many people do, but some people, they get post-viral infection syndrome. They feel lethargic even up to a month later. So for this one, the discretion would be up to the doctor itself, managing the patient.
Yeah, again, another favorite question that we saw is that about reinfection. A patient having infected with COVID, do they have chance of reinfection again?
Right. Reinfection has been described. There have been a few case reports of reinfection. Generally, it is thought to be a rare event because we are talking about tens of millions of people around the world having had COVID, but the number of case reports for reinfection is few and far in between. Of course, we know it is underreported. In my hospital right now, we have at least 2 patients who are reinfected, and we do know for sure that reinfection can happen. It is thought currently that it almost always happens after 3 months. That means if you have gotten COVID the first time, for the next 3 months, it is very unlikely for you to get reinfected with COVID. Reinfection can happen because of 2 ways. One is because of waning immunity. We don't know how long a person's antibody levels will last after they get COVID. It's been shown that in mild COVID, the antibody levels are not so high and they disappear earlier. In severe COVID, the antibody levels stay high for a long time. So the antibody levels in the body will determine how long you are protected for. And the other thing is also the viral mutations, because if the virus mutates sufficiently, then your earlier antibodies may not be sufficient to cover for the next mutant that comes along. But it is generally thought that within the first 3 months, you are sort of like protected against getting COVID again.
Dr. Benedict, one of the biggest challenges that the general practitioners face, especially, is that when they have a positive case, for them to notify. Of course, e-notification and all is not so far. But to get in touch with any of the PKD officers or CAC is very, very difficult. This is a nightmare for the general practitioners. Can Dr. Azhar, Dr. Rohani comment on it?
Hi. Well, I know a lot of complaints about PKD not picking up and CAC not picking up. Well, I can't comment on behalf of the PKD, but they are really like at Petaling itself, they are really overworked, and the phone lines are using to call the patients who are positive. But CAC, like our CAC, we use WhatsApp and Telegram, so we will respond if the patient WhatsApp and Telegram. Rather than calling, we take a longer time to respond.
So I think is it okay for me to say that we can pass the CAC number, WhatsApp number to the patient for them to communicate directly with you?
Yes, yes. Actually, okay, I will pass afterwards. The like Selangor and I think other states, so they have their poster where their CAC are, and also the contact number and the operational hours.
Thank you, Dr. Then there's another question here is how about static antiplatelets in the COVID-19 patients, especially those with IHD, other comorbids?
Sorry, antiplatelets, is it? Yeah, I think that's one thing that it's being trials are being carried out using statins, using antiplatelets, because the most common complication of patients who get severe COVID is what we call as a hyperinflammation state. But there's also a competing theory which says that in some patients at least, it may also be caused by hypercoagulability. That means the blood just you get micro thrombi in the blood vessels in the lungs and all that. And so there's a theory that if you give them things like statins and aspirin, that will help to prevent it. We are using low molecular weight heparin in all of these patients. Any patient who requires oxygen automatically gets low molecular weight heparin, which would probably be more effective than aspirin at this stage. But I know that drugs like aspirin and statins are still being studied as to see whether there's over and above low molecular weight heparin, whether that makes a difference or not.
How about patients who are already on ACE inhibitors or ARB? Are they in a higher risk?
Yeah, there was one of the early questions that came out. Patients, because the COVID germ gets attached via ACE inhibitor, via the ACE receptor, and so patients who are taking ACE inhibitors, are they benefit? Is the drug beneficial or is the drug worse? And I think most studies have shown that there's actually neutral effect. So current guidelines say that if you're on an ACE inhibitor, just continue on the ACE inhibitor. But if you need a new antihypertensive during your acute phase of COVID, they suggest not to use an ACE inhibitor at the moment until more data is gotten.
Okay, thanks, Dr. Ben. One of the challenges that patients, COVID-19 patients face is the stigma of the society. The question here is that how long does patient need to wait before a positive patient would like to mix with the public again?
Right. I think the main reason why they may not be able to mix is because of the infectivity. So once they are no longer infectious, so for mild disease, we are saying it's beyond 10 days, they are no longer infectious. Actually, they can mix around. But some patients understandably may be reluctant to do so because some of their symptoms may not have completely gone away by 10 days. The cough may last for another 10 days more after they are discharged. So so understandably, some patients may be concerned about going back to work earlier because the workmates may know that, hey, this guy has got COVID and now he's still coughing, and why is he coming back to work? So sometimes there is that fear there, and so they want a longer period of MC, and I think that's acceptable, there is a psychological burden, unfortunately, for patients who have just recovered from COVID. Now, in a way, the fact that some of the big shots in the country have gotten COVID, hopefully it will sort of like help to dispel some of the some of the stigma that has been going around.
Okay, Dr. Ben. This is one case study here, Dr. Ben. It's a symptomatic patient who completed 14 days. So the second PCR was negative. And then the patient went back to work. After 5 days, the patient had the URTI symptoms. How do you approach this case?
Right. So within the first 3 months, we are saying that it's extremely unlikely for the person who has gotten COVID to have a reinfection. So if a patient redevelops symptoms shortly after his COVID event, it can be two possibilities. One is that the patient actually has lingering symptoms which wax and wane, that comes and go after COVID. For example, after any upper respiratory tract infection, patients who have got a lung that is hypersensitive may actually continue to have some bronchitis or continue to have some post-infectious cough, which can last up to 3 weeks. So the same thing can happen with COVID as well. But the patient is no longer infectious anymore. The other possibility is that the patient may have picked up another infection along the way. With social distancing, other viral infections are thought to be less as well. However, in a case where a patient has gotten severe COVID before, many of them leave hospital with damaged lungs. And damaged lungs, that means they've got lung fibrosis, they are still on steroids, so the immune system may not be that great. So these patients can actually get recurrent infections. So for the time being, any patient within the first 3 months, if symptoms recur, we are not considering that this could be COVID again. However, on a case-to-case basis, if, for example, a patient is re-exposed, has a high-risk exposure once again after being released from hospital, and then 2 weeks later he had a high-risk exposure to COVID again, and then he redevelops the symptoms a few days after that. That one, on a case-by-case basis, it can be discussed with the infectious disease physician, where we will see whether we would first screen for other infections before we consider COVID. Because the whole theory behind it is that he recovered from COVID by producing antibodies. Okay, and his antibodies should be protective for him at least for the next 3 months, yeah? So that's why we don't expect reinfection so fast. Sorry, I hope I answered the question.
The next question is, despite being notified about the patient, and also MySejahtera app has been filled and sent by the patient himself, there was no communication from PKD or CAC for the full 10 days. Upon completion of 10 days of quarantine, can the patient go back to work despite there's no communication with the PKD or CAC?
Okay, I take the question. I think, yeah, a lot of people, especially at the Klang Valley, they has passed 10 days of their isolation period, and they are still not contacted. But what they can do is, when they come to CAC, we will give them like a sort of a discharge note saying that they have now, after they have completed the isolation and whatever days that and they have no symptoms and they can go to work. So we will give that to them. The CAC has just started, I think, about 1.5 weeks ago. So we hope to cater everybody that has been infected with COVID-19. And we know there are a lot more people who has not been contacted, but they can, preferably if they can get in touch with the CAC, we will give them appointment. But if they come walk in, we will also entertain them. But preferably it's with appointment. Some employers ask for a discharge note, you know, before they come to work, and some requires MC. That's why some they will still require to come to CAC if they need the notes.
Thank you. There's a very interesting question here. Is a COVID patient CT value plays a part for deciding whether COVID positive patient has completely recovered from infection? Can we repeat PCR test to see the CT value after 10 days of quarantine? What is the CT value cutoff point that we can say patient is non-infectious?
With regard to CT value, is actually quite it can be tricky. What we do know is that high CT values means a patient is non-infective. So if you happen to do a repeat PCR and the CT values are high, what do you mean by high? It's tricky because as Dr. Gunn mentioned before, there are different platforms of PCR, and there are numerous platforms of PCR. Each one has its own cutoff for what is significant. Generally, we all accept that more than 35, that definitely this patient is non-infective. And I think from viral culture studies, more than 30 also, they have not managed to grow the virus now. Yeah. If a CT value is very high, yes, it does give added information that this patient is no longer infective. However, a low CT value does not automatically mean the opposite. A low CT value does not automatically mean this patient is still infective, because if we go back to what a PCR picks up, genetic material. Okay, the genetic material of the virus. So after a virus is broken down, the genetic material still remains, but the virus is no longer viable anymore because the gene sequence has been broken. So so the PCR test may continue to be positive, and may continue to be positive even with a lowish CT value, but it's not a test to say whether the patient is infective or not. An analogy that I could give is like, somebody tries to find out how many people are living in a city by counting how many skulls there are. Most of the skulls belong to people who are walking around and breathing, alive and kicking. But there are also a lot of skulls which actually belong to dead people. So a PCR is actually counting how many skulls there are and trying to guess how many people are living in that city. So it picks up remnants of the virus as well.
All the answers that are given. We have come to what 5:30, 1 hour. Then the time that is supposed to close. Thank you everybody for being with us this evening. We noted there have been about 700 people for us today, and we hope we in MMA will try our best to engage with MOH with all whatever decisions they're taking. And to all the speakers, thank you so much. Before we end, our MMA General Secretary, Dr. Arasu, will give you words.
Thank you, Dr. Siva. First of all, I'd like to thank Dr. Ben and his colleagues from Ministry Malaya and also Sungai Buloh from Hospital Kujapa for making this possible. And also a special thanks to Ministry of Health, especially buying a lot of jacket, and Dr. Donaiti and Dr. Rohani for engaging the GPs. And we are looking forward for more such engagements directly with GPs so that we can find a more conducive working environment for both parties for the benefit of patients. With that, thank you very much and stay safe. Dr. Dato, you want to say anything, Dato?
Yeah, Doctor. Okay, I think before we end this session, on behalf of the Ministry of Health Malaysia, I would like to thank Dr. Arasu and Dr. Siva and everyone here for having this very fruitful discussion. I think, it's opening up of everyone. Hopefully, it's a learning session. We share your experience as well as with our teams at Ministry of Health level, hospital level, district level. We hope we can have more collaboration with GPs from time to time. Thank you very much to everyone. and take care. Take care.
Thank you, Dato'. Thank you, Dato'. See you all again.